and finish early, God willing. We have briefings and then hearings. I want to thank everyone that came to be with us today. We really appreciate your time and certainly do not take it for granted. For those of you that are watching at home, you'll be able to be part of the process as well. Thank you so much. So good afternoon and welcome to the House Health and Government Operations Committee. I am Jocelyn Peña-Milnick, Chair of the Health and Government Operations Committee, and to my left is my amazing Vice Chair, Delegate Bonnie Collison, and to my right is the lawyer for these topics that we will be discussing today, Lindsay Road as well. Thank you. I kindly ask for your patience if we encounter any technical streaming issues. Sometimes it happens, but just be patient. We will get to it, okay? This briefing is being streamed on the Maryland General Assembly YouTube channel. And something that is different this year is that we have closed captioning now, so it can pick up side conversations. So please be aware you do not want your conversations out there as well. Also, we have a wide shot camera of the rooms. It's not just the person that is speaking, so just to let you know that. This briefing will be on the YouTube channel live right now. Before this briefing, all members were emailed a copy of each of the presentation to your mailboxes, so you have it. If you don't have it, please let staff know. I want to thank staff for your hard work, and Michelle, who's in her office, and Andrea and Edith, and the 3 lawyers for the committee for your hard work, and all the clerks and the receptionists. You are the people that keep us together. For the committee, I ask respectfully that you are here to our usual committee rules of 1 question and 1 answer from the panel, not for each panelist, because then we'll be here forever, and I won't then get you out of here on time. Please keep in mind, after this briefing, we're scheduled to have bill hearings, so you know, we may have, depending on the time, a little bit of a break, but please make sure you come on time. As always, I appreciate it. Today, the Health and Government Operations Committee will hear presentations from the Maryland Department of Health and the Board of Nursing on issues relating to the Board of Nursing, followed by presentations from the Department on school-based health centers, which I know my Vice Chair cares deeply about, and the Office of Minority Health and Health Disparities, which I know many of you care about as well. We will begin with Secretary Laura Herrera Scott from the department. Secretary Herrera Scott, will you please be so kind and come up and bring whoever you want on your panel with you. And we're going to be doing now the Board of Nursing update for the committee and those of you at home to follow. Good afternoon. How are you?
Good. How are you? Good afternoon, Madam Chair, members of the committee, Vice Chair Collison. For the record, I'm Secretary Laura Herrera Scott. I'm joined today by Chief of Staff Erin McMullen of the Health Department and Rhonda Scott, Executive Director of the Board of Nursing. Next slide. So most of the presentation is going to be done by Erin and Rhonda, but before I turn it over to them, I just wanted to say that the work we have done with the Board of Nursing and the relationship with the Board of Nursing and the department is really a path forward for how we think about all the health occupations boards as we better serve our healthcare workforce in Maryland. On the slide in front of you is a summary overview of what we're going to be talking about. We're going to be providing updates on the progress that has been made since the 2 separate independent evaluations were conducted at the board. As you recall, in the legislation, the Maryland Department of Health had to have an independent evaluation, but at the same time, then OPEGA was reviewing the Board of Nursing. The updates we will be providing are not exhaustive, but generally cover the major findings and recommendations in the 5 areas listed on the slide, which were predominantly staffing, complaint response and investigation, fiscal responsibility, technology and application processing, and then constituent services and communication. And with that, I will now hand it over to Erin McMullen.
Thank you, and thank you, Madam Chair, Vice Chair. I'm happy to be with you all today. For the record, I'm Erin McMullen, Chief of Staff at the department. Before we delve into the updates in the areas the Secretary outlined, just wanted to provide you all with a quick timeline of where we've been the past 2 years. So 2 years ago, when the secretary and I joined the department, there were a number of issues related to the Board of Nursing that quickly came to our attention. You probably recall that licenses were not being issued in a timely manner. Nurses were taking off work to renew their credentials, or in extreme cases, we were getting reports that people were getting pulled off floors of healthcare facilities because they couldn't get their license issued. You were hearing the same thing that we were hearing, and a request was made of OPEGA to conduct an independent evaluation of the board. You all also passed emergency legislation that moved infrastructure and operations of the board under to the department for a 2-year period. And that emergency legislation, as the secretary noted, also required us to procure an independent evaluator. So both those evaluations were issued in 2023, and last year we were provided you with updates across all of those areas of findings and recommendations. I think we're back in front of you today really to talk about a lot of good news. The partnership with the board and the department is incredibly strong, so strong that the volunteer board voted to extend the secretary's authority over infrastructure and operations for another 5 years. I think today we're going to share a lot of updates with you that have been resolved, but there's still more work to be done, and the department remains really committed to working with the Board of Nursing. It truly, as the secretary said, has been a wonderful partnership on how we can support our healthcare workforce. So with that, we'll move over to the staff-related findings from both the independent evaluations. The next slide provides an overview of progress in the areas to address those findings, as well as other notable milestones at the board. So the items on the slide that are listed in red are areas that we updated you on during the last legislative session. As a reminder, appointing a new executive director, Ms. Rhonda Scott, was done in September of 2023, and we enacted legislation last year in Maryland to change the requirements for the ED of the Board of Nursing. Those 2 actions resolved some of the findings from both OPEGA and then Ernst & Young, who did the independent evaluation of the board. I'm going to spend a little more time talking about the gray areas that are on this slide. Those are things that have happened since we were last before you during the 24 legislative session. So as you can see, there's been a lot of additional hiring underway in the areas of IT and then operations. The department's Office of Enterprise Technology, which is led by Clint Hackett, who was our now deputy secretary, but CIO at the time, worked really closely with Rhonda and her team to recruit someone for the board who had the technical expertise to help manage their existing systems, but also to help take the board to a next level when they get a new licensure system, which the secretary will talk about in more detail shortly. I'm also pleased to announce that as of today, there's a new director of operations at the Board of Nursing. This individual is going to be charged with helping to further streamline operations and address some of the areas that are still in progress with the board. So this slide here just touches on a few other related findings from EY and from OPEGA. I'm not going to go over all of these, but I do want to underscore that at both the department and at the board that there has been a very concerted effort as we think about employee retention, retainment, and frankly just being responsive to employee needs. This ranges from regular town halls that the secretary leads for the entire department to recognizing outstanding employees, including those at the Board of Nursing, through the secretary's employee recognition program. Board leadership has also instituted a number of initiatives to improve the culture at the board and create really a culture of continuous improvement and a high emphasis on customer service. We have a lot of good news to share there. With that, I'll hand it over to Rhonda to discuss the next domain on complaint response.
Thank you, Erin. Good afternoon, Madam Chair, Vice Chair, and the committee. Appreciate this opportunity. For the record, my name is Rhonda Scott, the Executive Director for the Maryland Board of Nursing. If you all recall that there were some concerns about the timeliness of investigating complaints and investigations for the board, and you can go to the next slide. And in order to address some of the backlog that we had, the department approved 10 contractual non-nurse investigator positions. We worked with the department then to revise the minimum qualifications, and we reclassified the position to better meet the requirements of the role. We've also developed new policies to streamline the investigative process, and we are currently actively recruiting for 5 non-nurse investigators under the new classification. Next slide. Thanks.
Yeah. The next set of findings that we're going to talk about relate to the fiscal outlook of the board. So one of the major findings from both the independent evaluations related to the board's fiscal solvency, and that includes the fees that they charge to licensees and certificate holders. So as a reminder, the Board of Nursing is one of 17 specially funded boards at the department. And historically, their expenditures have solely been supported by the revenues that they bring in via licensure fees. However, over the past several years, the board was not bringing in enough revenue to support its expenditures, and they started out fiscal 2024 with a negative fund balance. So absent support from the General Assembly, the infrastructure, the support that was provided in the budget last year, without that money, the board would have ended the fiscal year with almost a $6 million deficit. Instead, they closed out the fiscal year with a $1.8 million fund balance. But I want to underscore that general fund support for the board was time limited, and both evaluations documented the need for the board to increase its licensure fees. So as you can see on the timeline here, steps were taken this fall to start initiating that process. The board developed draft regulations and they solicited them informally with stakeholders. There were over 4 stakeholder meetings. I think they received hundreds of comments and feedback through those sessions. Those regulations should be coming before AELR shortly and move into the public comment period. The next slide does outline the fee update that will be coming to AELR shortly. I do just want to note that there's a number of factors that were considered when this fee schedule was proposed. And so many of the increases I think we do want to acknowledge are sizable. The board has not increased their fees since 2007. And the fees are necessary to support existing expenditures as well as the new licensure system that the secretary will speak about shortly. So first, these fees were developed on the board's, based on the board's FY24 actual expenditures. So with those increases that you see on this slide, the board is essentially breaking even. They won't be maintaining a fund balance under this proposal, but they will be able to cover their actual expenditures based on the prior fiscal year. Once this new fee schedule is established for RNs and LPNs, the board is going to take a phased approach to look at their other fees that they issue to get to a place where they have an appropriate fund balance moving forward. The second thing that I just want to highlight that was considered as part of this, extensive research was done on the fees that are paid by other states. That was done by both OPEGA, done by the board, as well as Ernst & Young that did the independent evaluation. Essentially, what was found was that our fees weren't comparable with our peer states, and we really strive to impose costs that would be fair because Maryland has been an outlier and their fees are significantly lower than other states. So with that, I'll hand it over to the secretary to discuss about updates related to technology and application processing.
Thank you, Erin. If we can go to the next slide. So this slide summarizes the progress we made over the last 2 years, and during the last legislative session, we reported a number of actions that had taken place to reconnect the board to the MDH network. As you know, they were standalone. They were on MiFi's, I think, just really old, outdated way to connect to even Wi-Fi. And so there was a lack of not only connection in their own agency, but across other agencies. And allowing that connection back to MDH resulted in several changes to further secure the board's IT infrastructure as well as raise the board's cybersecurity infrastructure. And since last session, I'm happy to report that additional steps have been made to move us forward to procure a new system. You've already heard from Erin on the new director of IT, but as you may recall, the current board's licensing system is 2 separate systems. There's one for the front end where the information comes in, then that information is downloaded and moved to the other system for actual processing of the license. So you can imagine that creates a great deal of inefficiencies as well as increased errors as people rekey information in, and that was certainly adding to some of the issues and the delays in licensing processing. And this summer and fall, we were able to secure additional business resources and obtain approval from DO-IT to procure a new licensing system. It is my hope that the new licensing system will not only meet the needs of the Board of Nursing, but other occupation boards that are interested in working with the department. So with DO-IT, we establish a major IT development project, or an MITDP, to procure the new licensing system, and this system will help us resolve several issues. We've listed the specific recommendations on the slide, so it should allow applicants to upload all required documentation electronically, robust complaint tracking database to be integrated into the licensing system, and then create automatic dashboards to replace paper reports. And that's including who is our workforce, who's currently working, and where are they working? Because we certainly want to think about the impact that COVID had on our healthcare workforce in general, yet at the time we didn't have the ability to report out on some of those specific details and or post-COVID understand who came back into the workforce. So this will help us understand better the workforce we have today. Next slide. So we're working very closely with the Office of Enterprise Technology, who helped us identify the path forward for the new system. Specifically, the department will leverage Salesforce to solicit a vendor that is able to demonstrate the successful implementation of a system in other states. And I want to say this idea came from, again, our Deputy Secretary of Operations, Clint Hackett, who was our CIO, and he came to us for Wisconsin. And Wisconsin had leveraged their ARPA dollars to build a new healthcare workforce licensing system for all healthcare licensees. So they demoed what they did in the state of Wisconsin, and we demoed it with several people from the Board of Nursing, and we all were immediately enamored with the system that they had, the ability to upload documents, the ability to track where your license is in the process, and it also flags for you any outstanding documents. I think some of you had heard me last year talk about the pizza tracker and Domino's. I think for those of you who order pizza or maybe have kids that order pizza online, you know when you made your order, you know when your pizza's in the oven, you know when the pizza's out of the oven, you also know when the pizza's at delivery, and it even gives you an ETA of when your pizza is going to be at your front door, and then it tells you it's being delivered. Well, now through this new licensing process, nurses and nursing supporting paraprofessionals will be able to see where their application is in the process. And if there are issues with the documentation that they've uploaded, they'll get pinged to say, you need to provide X, or that's incomplete, et cetera. So other states, including Wisconsin, Ohio, Oregon, New Mexico, Texas, and DC, have successfully leveraged the Salesforce platform to meet similar requirements. And state of Wisconsin has generously agreed to give us a head start in the project. They are giving us actually the code and the architecture that they built for the process, the system that we demoed, that would allow us for a quick addition of other license types as other boards desire. So the timeline to get the system set up is running and is listed on the slide, but we're pretty excited by the work ahead and the licensing system coming online. And with that, next slide. These are some additional findings related to technology and applications. So I'll leave it to you to just read some of what's on there. But just to say that they're not all going to be fully resolved by our new system. However, the actions the board is taking to help resolve the findings and address outstanding issues are included in the document, and certainly under Rhonda's leadership continue to be addressed. So with that, I'll turn it back over to you, Rhonda.
Thank you. Okay, next slide. So we're going to look at some of the constituent services and communication findings and progress that we've made. So to resolve the recommendation to educate our constituents and stakeholders, the board held several town hall meetings, including Q&A sessions over 2024 and 2024. And we provided FAQs and information on how to, apply for a license, tips on, if you're delayed, what could cause a delay and things like that. And we're going to continue to initiate town hall meetings going into this year as well, just to identify and help folks through the process of application and managing our system until we get our new licensing system onboarded. One of the things that I did want to mention is that since December of 2023, we have currently maintained a zero overdue constituent inquiry cases from the MDH Office of Constituent Services. Around this time in 2023, we were at about 197 overdue cases that constituents had submitted, and we were still trying to work on them. We have maintained zero overdue constituent services since that December of 23. There are findings, again, that are still in progress. We have, if you recall, we updated our phone lines, added additional phone lines in September of 2023. And we hired additional licensing and certifications team members to assist with processing as well as answering phone calls. In October of 24, we installed a new licensing system. This system is equipped with a time check option to let callers know where they are in queue and also give them a callback option. We're working with our IT department and leadership to initiate on-demand reports that will give us information on the time it takes for a call to be resolved, the time it takes the person to call to be answered. And these are just some of the things we're looking at to determine whether or not we would need a call center and if we, the volume of calls is actually being addressed by the current staff that we have. As far as our communication plan, we currently work with the department's communications office to respond to media inquiries, but we are working on developing our own communications unit. We are drafting the position description for a communications specialist to help us work on these efforts. In addition to us migrating over to the department's SharePoint platform, we are planning additional website changes to improve user experience, starting with internal website governance committee to oversee the site layout, content changes, ensuring that what's there is accurate and up to date. Next slide, please. And so this is information that we had for prior feedback, where we were around March of 2023. And many of you may recall, we were, again, having many concerns and complaints and inquiries about service that was being provided or not being provided and the gaps in service. And at that time, our Google ratings were at 1.2 out of 5 stars. Next slide, please. We are actually very pleased to, in the progress we've made in our customer service. We are now at a 3.2 stars with our Google rating. Our Yelp review, Reddit reviews, all are increasing. I want to make sure that I say that we understand that there's more work to be done, right? We are far from finished. There's more to be done. However, we're very proud of where we've come from and where we are now, and excited about where the board is going. Next slide, please. And that brings me to the departmental legislation and the board's legislative initiatives. And so, you can turn to the next slide. And so the legislation that the board's departmental legislation includes our sunset extension. And along with the sunset extension, the board has voted to extend the Secretary of Health's authority over the board's infrastructure, as well as HR operations, for an additional 5 years. The board members base this decision on the successful partnership that we've developed with the department and the support and overall support from the Office of the Secretary. There's continued operational support from the department. The Office of Enterprise Technology has been very instrumental in assisting us with upgrade to our IT infrastructure. And the board feels that that additional technological expertise will be very instrumental in helping us through the major IT development project that is underway. We've also had tremendous support from the department with timely recruitment and onboarding of staff that's been very helpful in getting positions filled timely so that we can get folks in the board to do the work. and also potential assistance with infrastructure costs. In addition to the sunset extension, the legislation also creates an alternative pathway for nurses seeking licensure by endorsement into Maryland. So currently, certain endorsement applicants who would not meet the minimum educational qualifications for licensure are able to do so through this pathway. And they would just, the bill permits these individuals to meet those qualifications for licensure by presenting proof of certain additional educational credentials. And the board feels that this is one way to really boost Maryland's healthcare workforce, addressing the crisis and improving, the number of practitioners coming into Maryland, addressing, certain gaps in access to care. Next slide. I think that's it. Yep. And with that, are there any questions? Thank you.
For your work. I mean, where we are today was not where we were when we started this whole process. It was so painful, so painful, as you know. And I'm glad that we're moving forward. And I want to thank you for your work. I want you to know that the committee appreciates it.
Thank you.
Madam Secretary and Ms. Scott as well, okay? I'm going to open it up for questions now. First, Delegate Kerr, followed by Delegate Rosenberg, then Delegate Woods.
Here in HGO, I chair the Government Operations and Health Facilities Subcommittee. We deal with state technology as well as state procurement. So I have a question about your new licensing system. Is that the Salesforce?
Salesforce is the chassis. We'll be putting out the RFP for the actual building for what sits on the Salesforce platform.
Who's your current vendor?
I think it's one of the, let me get back to you because I think we're using the vendor through the DGS. We're working with DGS on the vendor and with DoIT. So I can give you the details of that. And I'd rather it come from our CIO than from me.
And once you had identified the specific business requirements for the new licensing system, do you know if the current vendor was given an opportunity, once you had identified these new abilities, was the current vendor given an opportunity to bid on it? Did you go through an RFP process?
So we will be going through an RFP process for part of it, but not for the infrastructure. We were trying to figure out the fastest way to get a licensing system online. So again, we worked in partnership with DGS and DoIT to see what are the vehicles that we have in place that we could build off of to implement a licensing system sooner than later. And so I think most state agencies use Salesforce. That's already in place, not only in our agency and other agencies. And as I mentioned, our Chief Information Officer, who's now Deputy Secretary of Operations, came from Wisconsin, and he said, you should take a look at what they're doing. It's a pretty robust healthcare workforce platform. And so we did, and we had many meetings with them, not only on their nursing platform, we looked at their dental platform, again, trying to think about a tool that we could build once, but then use it multiple times. So that's how we ended up with Salesforce as the chassis, and the details of the other pieces we can send you a memo or an update of what that process is going to look like and what's going out for bid next.
So there was no bid process?
Not on the total project, just what's coming out as the bid related to build it on the Salesforce platform.
And the current vendor didn't participate?
The bid is not out yet, and assuming that the vendor can build the platform, they would be eligible to apply like everybody else.
Thank you. And thank you for the indulgence of multiple questions, Madam Chair.
So might as well ask here, not later. And I always look to my left, so I'm going to look to my right. Delegate Kipke.
Thank you, Madam Chairman. I too want to thank you for the work that you've done to reform the board. And I'm curious, you talked about like the Google reviews and the Yelp reviews. Is there any, the MVA years ago implemented a thing at the end of every interaction where they ask you, how well did we do today? Happy face, smiley face, or push 1 or push 2. Has anything like that been considered? And if not, I asked you to consider it because the MVA has gone through a dramatic improvement since something as simple as that took place. Thank you.
Thank you. And just to respond, we actually attribute a lot of our success to the QR codes that we post, and we ask our constituents after interactions with our administrative staff to rate their interactions, certainly give an honest review of their experience. And we also have an individual who looks at the reviews in real time and responds to negative interviews to do some service recovery.
Very good. Thank you.
You're welcome.
Rosenberg.
Thank you, Madam Chair.
You're welcome.
Have you taken as a department any steps twofold to prevent an agency or an entity within the department like the board from falling to the level that it had? And on the upside, have you, the pizza delivery or something else, tried to, or looking at how you can also implement the improvements that you've made here elsewhere in the department?
I'm going to be brutally honest, the boards remind me on a regular basis that they are independent bodies with their own governance structure. And by virtue of the work that you all did to move the Board of Nursing under the Maryland Department of Health, we learned from each other that we want to partner, and we can do more together than apart. I will tell you that Erin McMullen and I were very surprised when the board voted to stay under the Department of Health, given some of the testimony that we heard 2 years ago on why they should stay independent. So great progress with the Board of Nursing. Certainly you all recall from years ago with the Board of Physicians, we still have some work to do with the other boards, especially the smaller boards. As far as the licensing system that we put in place, that's why when we looked at it in Wisconsin, we saw how many other licensing entities it was used for. And with modifications, it could easily be retooled to become a dental licensing platform or a social worker licensing platform. Wisconsin actually used ARPA dollars to fund their entire new licensing structure. And because they used federal dollars, they willingly shared the code to do that work. So we are benefiting from another state that used federal resources to build something to serve us. So we think it can do all the other things and serve other boards, but the boards have to be willing to look at the system and agree that it can meet their needs.
I would just add, we do have the authority as the legislature to mandate certain things if we reach an agreement that, well, we don't have to reach an agreement, if it's in the best interest of the department and of the people served by the department, as you know. Thank you.
Thank you.
We're here for the next how many days, ladies and gentlemen?
76.
76 days, and who's counting? Okay, so we have Delegate Woods, followed by Hill, followed by Alston.
Thank you, Madam Chair. Thank you, Madam Secretary, and congratulations, Ms. Scott, on your Executive Director position. I think that was part of my question as to how we could use other licensing platforms to put together some of these things that make the process much easier. The question that I have, though, because we see now that we're trying to move all of our licensures to electronic processes and trying to increase the IT availability, what, if anything, has been thought about as it relates to using maybe like an artificial intelligence structure to help with things that in all of these licensing processes people have to do the same, i.e. taking fingerprints and making sure that there's a system. You don't need a person necessarily to do that, to make sure those things are in order. Those clinical exams that people are taking that are done electronically, has there been a thought about putting systems in place that could actually prevent having to have, you understand what I'm saying, an individual, but having systems that could look at those and then put them into the proper places, because that has been one of the biggest concerns about a lot of people, as you know, that we're dealing with the whole snail mail process, submitting information getting lost, you know what I mean, or waiting for different systems. Is there a way where it can just all electronically go and have a system to put it together, maybe on a dashboard, so that it's there, so that we know it's there? It doesn't take 2-3 days or weeks to make that happen.
In the new licensing system, the workforce will be able to submit whatever documents they need to prove that they are the licensed entity that they say they are, and it'll upload to the system. And then it will show you where your licensing application is based on uploading of those documents. It will also ping you, so push out an email to the individual if there's a problem with something in your application, so you're not sitting there waiting and wondering. As far as the use of AI, it's too soon for us to tell. We have to build the platform and then test it. We are looking at processes end to end, because we don't want to build inefficient processes into the new licensing system. So we are looking at efficiencies in how we process applications as part of the new build, especially because, as I've already said, and Rhonda can attest to, we have two systems, one for the front end and one for the back end. So at the very least, we know we will get rid of that middle efficiency of moving data from one platform to another. But that is something that we will be looking at as we take the system live.
Thank you so much. Thank you, Madam Chair.
And just to follow up on your question, DoIT, the secretary was here last week, I believe, and they're doing and considering some pilots. And we recommended the Board of Nursing for one of those pilots. So if you can communicate with her, that would be great. I think that she will be open. Delegate Hill, followed by Olston, then Vice Chair Collison.
Thank you, and thank you very much for being here and for the work you've done over the past couple of years. And Madam Secretary, I want to particularly thank you, because I know you've taken on a lot, and there's been a lot of pressure. So I appreciate
That's an understatement, but thank you.
And we will have you back to discuss those other issues, I'm sure. So the two small questions that I'm not going to ask, because I only get the one, is I'm just curious about the Wisconsin code and if that's a security risk. And the other one, but the question I really want to ask is the constituent service, the telephone line. I didn't ask that question. I didn't ask the question. And I was going to. There was a second one I was going to not ask. Wow. But so you said you put in more lines, you hired more personnel. I just think that's so key, and I really want to get more feedback on, is that something that you think of as you just built it up to get over the backload, or do you think that having live people to actually answer phones, to actually look at emails, is something that should be carried out for the foreseeable future? Because I think it's critical that people actually feel that they're being responded to.
Absolutely, and I think the human interaction is appreciated by our constituents. I took a call myself when the lady was so happy to get someone. She's like, I didn't care if you were the janitor. I'm just happy to talk to a person, right? And so this is something we recognize that needs to be ongoing. As we implement the new licensing system, that may open up opportunities for us to utilize staff to assist with the call center. We're just, looking at different options right now, but absolutely, it has to continue.
And the question I didn't want to ask has to do, you talked about the town halls. Maybe you can tell us later how many people actually participated from the public. You had multiple ones. It'd be nice to know.
So the town halls I do are only for internal staff only.
Okay.
They're not for the public. We open them up to the entire workforce, and I think we've averaged between 1,700 to 4,000 people are calling into the town hall, and we have different topics. I also now regularly push out any changes in leadership so people know in the past they didn't feel like they were connected. And then, as Erin mentioned, we have what we refer to as the Secretary Spotlight, where people will nominate people that are doing good jobs. And we have customer service, innovation, what's the third
I
bucket?
think there's a team award.
Oh, and
too.
team award.
Yeah.
So leaders or even peers are nominating their peers, and it's the facilities, it's the local health departments, it's Preston Street proper. And it's not a big deal, but we give an award. I'm prior military, so for any of the veterans in the room, I also have my own coin, so I give a coin as part of the day. And then I'm going to whisper this part. I bring in Dunkin' Donuts. So it's not the healthiest option, but it's a little way to celebrate the incredible work that the staff do.
Krispy Kreme.
And can I just add that it is a big deal for our staff. One of our team members actually was selected for a Secretary Spotlight. And I can't tell you, when he came back to the board, he had his head held high. He took pictures. He showed off his coin to everybody. It does make a difference. And it's the perfect addition to what we were doing internally to improve employee satisfaction.
We always say in this committee, you get more with honey than you do with vinegar, right?
Absolutely.
And it's those little things that make a difference. It doesn't take much, right? Everyone has problems, right? But it's just a smile, a word of encouragement that really makes a difference. And by the way, I like my donuts like really plain. And I like key lime pie too, anyway. Let's see, Delegate Olston.
Thank you, Madam Chair. My concern is about the 5-year extension of the sunset, and I'm wondering why 5 years? It'll cross administrations, which always gives me some kind of angst. But more importantly, if the boards are supposed to be independent, what are we doing to move the board back to independence? And if they're not supposed to be independent, are we looking at getting all the other boards under the secretary? So if you could just elaborate on that, whoever is best to answer.
So I can tell you that the board, I know previously our sunset was 10 years, and the board thought that the 5 years would be reasonable. They didn't consider the administrative change. They're more looking at the partnership that was developed and how much it has meant to the board and how much it has been instrumental in our success. As far as moving back, I think that is certainly more than enough time for the board to, have its fee increases go into effect and, obtain our fiscal solvency to be able to be independent again. The idea is not to sever the partnership or the relationship with the department, but just, I'm assuming, to just give the board back its quasi-independence. Yeah.
And if I may follow on this, that board, and no, it doesn't reflect you because you came in to clean a lot of this stuff, was a wreck. We will get so many emails, all of you, of people during the pandemic that were waiting for their licenses in order to practice, even afterwards. And it was a unique situation that needed intervention. And I want to thank the department for taking it on because it really was a wreck. And as you know, nurses are very important, right? We have a shortage and we cannot make it difficult for people to get their licenses. And we need to get rid of a lot of the red tape. I know myself, I will call and I could not get a person to answer. And it was very frustrating. And then when I would send an email, because it came from my office, it would get taken care of and I would get really frustrated because it shouldn't take a delegate or senator to contact your office. Everyone should have access as well. So I want to thank you for cleaning it up as well. We have next Vice Chair Collison, followed by White Holland, followed by Johnson, followed by Bagno.
Thank you, Madam Chair. And I, too, want to give you my kudos. You've done an amazing job. Thank you so much. And I think one of the great lessons coming out of what you've done is building that collaboration and defining that collaboration. And to follow up with Delegate Olson, I'm hoping, this is not my question, I'm pulling a Delegate Hill here, I hope that there is a plan for transition and that clearly identifying the interactions but continue the collaboration beyond the, up to and beyond the sunset. But I do have a question. It's about staffing in nursing homes. And I'm hearing that there's been some glitches in the testing for CNAs, and that's caused an issue with, not enough staffing in the nursing homes. Is that something you all are addressing? And if so, what's happening there?
Absolutely. So the board actually took deliberate action to address this issue. We've been aware of it. And what the board did was vote to add an additional testing vendor to provide additional options for our candidates who are waiting to test. In addition, the board, the current vendor came before the board, they basically gave us a plan of action of what they're doing, and we are meeting, board staff meets with them regularly each week, and we provide updates on our websites for constituents on where they are with improving their progress with getting testing available to our candidates. We're still working through the procurement process with the new vendor, but we're hopeful that will be implemented extremely soon. And we are also working with the current vendor to secure a location to conduct a mass testing event to address backlog.
So the second vendor is not online yet?
Not yet, but we're working really diligently to get them online.
Okay, great. Thank you very much.
You're welcome.
Thank you all for being here and providing this update. Indeed, it really is exciting to hear about the technology in which that we are embracing in these new systems. I would like to know if you could expound upon the training, right, that it requires. When we talk about Salesforce, that's CRM to me, and I know that there are certain perceptions that we all have when it comes to CRM, and even for our legislators, we all have been adopting new technologies as well as it relates to our constituent engagement in cases, if you will. And so could you expound upon what does the training look like, and how does that even inform future hiring and capabilities and expectations of staff, and even the timeline for implementing these things moving forward? And so what does the training plan look like, and how long does that take, and what could that future look like when it comes to hiring?
So we don't have the training mapped out, as I mentioned. We have the chassis, but we have to put out for bid for the architecture to actually build the actual system. The one thing I will say about Wisconsin, and you please weigh in and your input, it was elegant in its simplicity. It didn't have all these extra things that you had to figure out. It was a very intuitive system. But once we get the vendor to do the work, we will be working with the Board of Nursing for the business requirements. And then as those business requirements will be laid out, then we'll understanding what testing staff will need, what testing and education we will have to do for new nurses or nurses renewing their license to say, hey, we have a new licensing system. We are going to have, town halls or open meetings to show you and walk you through, and then not just training for the staff, but even call center activities. So as we go live, to make sure that they're adequately staffed to handle calls with people that may not know all the clicks that they need to make. So all of that is in a high level plan, but I don't have the details on training because we haven't collected the business requirements yet. We don't have the vendor, one, to build the architecture. And once we have them, then they'll need to work with the board on the business requirements.
Okay. Madam Chair, if I'm, so given that, I mean, you said that Wisconsin was your model, right, your framework. And so do you have a sense of what it took for them to get online, given that we're using the same code, knowing that it's going to be built out further? But if we could just, get a sense about what their rollout looked like. Is there a story you have?
I think they did it in 6 months.
Yeah. 6 months.
Now, they admittedly said that was too fast. So they admittedly said that was too fast. They were trying to bring additional clinicians on during COVID to address the needs of the state, and so they wanted a system that was up and running quick so they could license quickly. But they said it was too fast, and there were issues with not only the staff knowing the clicks to process a license, but even the nurses and the nursing staff, paraprofessionals, and their ability to know the clicks that they need to use. So we will learn from them on where the pitfalls were in that 6-month timeline. But they admittedly said 6 months was too fast.
Okay, all right, thank you, thank you.
Actually, Skip Johnson. Sorry, 1 second. Yes, I did, Johnson.
Well, thank you, Madam Chair. And thank you for coming today and letting us know what was going on. And thank you to the board for being willing to be partners and try to work some of these things out and get some things working better on the Board of Nursing. My question is on the fees. I looked through the other states, and I did see 4 states that were higher than the $230 fee. One was the same. But what really interests me was a few states offer a discounted rate, including Wisconsin, for new graduates. So have we thought about doing anything like that to persuade graduates to come to Maryland practice or entice our Maryland graduates to stay here and practice?
When we developed the fees, we did look at the other states, but we focused on where we are now and where we needed to be fiscally. And yes, that, would probably be a good way to entice folks to come, but we feel like our fees are still competitive with our sister states and particularly our surrounding states where we get a lot of applicants from. And so we didn't think that that would be necessary really to, entice more graduates to come to Maryland.
So you didn't think it would be advantageous at all?
It's not something we considered. It could be, but again, because we were looking at the competitiveness and what our sister states' fees were, we thought that, we wanted to stay, competitive with that rate.
Because I saw like Wisconsin, $75 for graduates. It seems to be like from $75 to $88. And that would, to me, it would make a difference for a new graduate. But thank you, Madam Chair.
May I follow up on that? About how many people, new licenses, do you get a year?
I don't have the exact numbers, but I can certainly provide it to you in writing.
Can you look and see what that will cost?
Sure.
Because I think that, especially given we have a work shortage and we're competing, right, with the DMV area, Delaware. I know we received some emails about, and I know I emailed your office about a couple of emails saying it was high and they were upset. What would that cost to offer it at least to new ones, right?
Right.
Thank you. And if you could follow up and send it to the whole committee, we like to share here. Delegate Shalega started that with her cake, and thank you, your beautiful granddaughters for the delicious cinnamon cake. If you're listening, it was delicious. 2 pieces. We do have Bagno. I have you.
Thank you, Madam Chair, and thank you for this presentation. And I echo my colleagues' comments about how much work has gone into this and thoughtfulness. And this may be putting the cart before the horse a little bit, but I'm sure you saw all of our ears perk up when you were talking about this licensing system and the fact that it could be utilized to bring all of our boards online, to be more efficient, to be more responsive. My question is, and again, this might be, as we're considering the technology, how it would be compatible with our compact agreements, because we do have a number of compact agreements now, and if this is going to be a national effort where we can actually share those records, I would just ask that would be part of the consideration as well. Isn't that so?
We'll add it to the list as part of the business requirements.
Thank you so much. Sure.
We'll have Gazzoni, because I saw her first, and then Hutchinson, okay? And Hutchinson, you can get 2 instead of 1. Go ahead, Gazzoni.
Thank you, Madam Chair.
You're welcome.
I wanted to follow up a little bit on Jennifer White Holland's discussion about training. I've done rollouts of new IT systems in the past and culture change work. So I was curious, not specifically about the training, but about generally your sort of plans for all the culture change that is currently going on and will continue to go on, and how, sort of like, do you have a change management plan? And how are all of the employees doing? Because this is going to be some significant change for an organization that has been in, I would assume, a level of change and uncertainty for a couple of years now.
Yeah, so one of the things that we established early on was great communication amongst, from leadership to staff, right? And they appreciate that a lot. So we hold regular meetings, updating them step by step on what's going on and what their involvement is. And they are even involved in establishing the business process because they're the experts, right? They do it every day. And so they appreciate that input, and they're extremely excited. They are overjoyed about the new system, the idea of having a new system, because if you think about it, it means less manual work for them, right? And who doesn't want their job to be easier?
Excellent. Just a quick.
Go ahead. Sure,
Isn't that true kind of thing? I will certainly say from all of my experience in change management, you cannot over-communicate.
Yeah.
Isn't that true?
Absolutely. Agreed.
All right, Delegate Hutchinson, you were so patient. You get 2 questions. Go ahead.
I need one, and it's actually a good thing you asked me to go last. It's not necessarily related to the topic of the day, but Secretary, it's good to see you. It's the first I've seen you since we've come back. But you mentioned West Preston Street, which made me realize, are you still in State Center, and was that the building that was subject to Legionella? How's that going? Is that cleared? And in 2 interims ago, you and I met, and you said you were actually going to move down towards University of Maryland Medical Center. And I just strongly believe that our health department should be in a really good, healthy, beautiful environment.
We do as well, but I'm going to let Erin take that question.
We are still at 201 West Preston Street, except during session when we're in our beautiful bunker. But yeah, we are still there. The building, there was positive testing for Legionella. We worked with our colleagues at DGS to remediate that issue in the building and send out updates to staff. The most recent testing was negative for Legionella, but I do think we are, still moving forward. We're not out of the building yet, is the short answer. But what we have been doing is working with DGS on how do we make the building we're in now meet our needs and meet our employees' needs? And to the point of over-communication, I think that is something that we have been trying to do with the employees that are in building. Over-communicate. The secretary mentioned she had town halls earlier. You talked about this in the town halls with employees, but we are trying to work with our colleagues closely as it relates to our building needs.
So is the other location still in play?
It is still in play, but the date has been pushed back.
Got it. I wish you well.
Thank you.
Thank you.
And just.
Why don't you describe the building for everyone?
I was actually going to use the word deplorable, but
We don't want to go there. Talking about that disease, there was a case identified at the Dorsey Run Correctional Facility. Has the Department of Health been involved in that?
So normally those interactions go to the local health department, and then the local health department advises and works with whatever is going on in that particular jurisdiction. And then if needed, it will come to the Maryland Department of Health under the leadership of Dr. Kalyana Raman, who you'll hear from in a little bit on School-Based Health Center, and he oversees the infectious disease team. So generally, the local health departments have resources to help facility or manage whatever it is, including how did they get Legionella. But then if needed, they will come up to MDH for additional resources if needed.
Wonderful. So I have a couple of questions, and this is, I don't like to surprise people, and I did send you an email about it. But we received an email from the Maryland Coalition Against Sexual Assault, and I know I emailed this week and it's regarding the forensic nurse examiners. And they're saying that the certification is actually taking longer than in the past, often 3 to 6 months or more. And I send you the case of one individual in Hagerstown, which you know that's a tough area to get people to come and work, right? Because it's out there, it's not the city, right? They're rural areas. And what can you tell us about those licenses? Because there seems to be a problem with those licenses.
So I will say that that is more the exception than the rule. We've actually decreased our processing times across the board,
Yeah.
and it just depends on the individual. But we have acknowledged that there are more, that there is some things that we can do to improve with our forensic nurse examiners, such that in my regular meetings with chief nursing officers, we discuss the issues with forensic nurse examiners, and we're partnering with the Maryland Hospital Association to resume quarterly meetings with that group to address these types of issues, processing delays, even changes in scopes of practice, and, so that we're up to date with our, regs and things like that, to help with their practice. So we're in progress of getting a contact person to engage with for the F&Es to further address these issues.
May I ask you, could you get in touch with Lisa Jordan? And
Lisa
Ms. Jordan
Jordan.
is actually the executive director of the Maryland Coalition Against Sexual Assault. And was she here? I know she was here earlier. So if you can, and we can give you her cell phone number. Like, before you leave, I'm gonna see if I can step out and give it to you, okay?
I'd appreciate
Just to
that.
make
Thank
things
you.
easier for you. And anything that we can help, I don't just want to bring a problem, let us know how the committee can help you, okay?
Appreciate it.
We are a
Thank you.
true partner.
Thank you.
All right, I have a couple of questions regarding, when you talked about complaints, you said that you have streamlined investigative process, but you didn't say how. Can you tell us how?
So there's a long process. I don't have specific details, but I can certainly provide the process details to you in
Okay.
writing. But some of the things that the board did early on was to delegate authority to board staff to triage incoming complaints. So instead of a complaint coming in and waiting a couple months to be triaged and reviewed by a committee because they were so overwhelmed, we have board staff triaging complaints the day they come in and then assigning them for either investigation or making recommendations to go to the board to ratify. So we've been able to decrease the complaints piling up and waiting to even be triaged. And then also we looked at streamlining just the timeline it takes for an investigator to draft a report. Sometimes could take a couple weeks of compiling all the evidence. So we've streamlined the process for that and engaging the prosecutors in reviewing the evidence and things like that. But I can certainly provide more detail in
Yeah,
writing.
if you can be so kind and send to the entire committee, sort of like, if you can quantify the improvement, like how many days from the minute you get it, right, until it's processed, that would be wonderful.
Sure, absolutely.
As well. All right, so any other questions? All right, and then you said for the procurement, you're going to be putting it out there, people are going to be able to bid on it.
I'm going to send you from the Chief Information Officer the process, so we're
Okay,
clear. I might have
wonderful.
misspoken, so let me just get you from the expert on how this process is going to work. It is going out for bid, but I think it's just the architecture, that piece of it. But again, I'd rather our CIO, and we'll get you a
Okay.
formal memo for the whole group to see.
That would be wonderful. Thank you for sharing. Any other questions? Oh, Delegate Rosenberg.
Is it still, you're still under, well, I don't know where you are in the process, but aren't you moving to the former Social Security building? Or am I mistaken?
That is the building that we're supposed to be moving to. But it's been delayed, the date has been pushed back
Because,
because of construction fees and escalating costs.
okay, thank you.
Thank you, Madam Chair.
My pleasure.
And thank you, Madam Secretary, and your wonderful guest. Thank you for all the work you've done. I was kind of like waiting, and it's like, well, maybe I'll ask her after. But anyway, did I miss that You said we bought the code. I don't know enough about IT to know what the code is or a vendor and vice versa. So Wisconsin is the platform we're going to use. We like it. It works. It sounds amazing. Do they have a vendor, or has that vendor been offered, or do they have to go through the process as well with everybody else? Or why can't we just have the same people?
So I don't know what process they use to procure their vendor. They have the same platform. I think every state has some business with Salesforce for different things in the state. But we have to bid it out. So we're working with DGS and do it on that process now.
But could you at least, if you don't know, ask them what their vendor's name is? Are you allowed to do that?
Yes, we can do that.
Okay,
Absolutely.
so I think that would be a good idea.
Any other questions? All right, I just want to thank you again on behalf of our committee for all your efforts, okay? I want you, Ms. Scott, to know that as you leave here that we are really grateful and that we are a partner, that whatever you need to get this work done, you let us know, okay? And Madam Secretary, and Erin as well, okay? Thank you for your patience as we ask the questions. This was a very painful process, right? So if you have a lot of questions, it's because we want to know where we are, right? And we invested, and the Department of Health invested $10 million into the board. It did not come out of the fees, and we're very grateful for that, okay? Thank you so much. Next, we're going to go on.
Thank you.
Have a blessed afternoon. We're going to go on to school-based health centers, and we have the Deputy Secretary for Public Health, Dr. Kylie Manarin, Maryland Department of Health. We have the Medical Director of Maternal and Child Health. So we have two witnesses. If you can be so kind and come up, please. And welcome to the Health and Government Operations Committee. I believe one of you, it's your first time testifying here, am I right? All right, will you can get started when you're ready.
All right, thank you, Chair. Thank you, Vice Chair and members of the committee. I'm Nilesh Kalyanaraman, Deputy Secretary for Public Health at the Maryland Department of Health, and I have Dr. Ben Wormser with me as well, who is the Medical Director of the Maternal and Child Health Bureau. I was just thinking that I haven't seen all of you in many months, so it's good to see all of you again. Thank you for having us here to talk about the school-based health center program. Is that a little better? There we go. Absolutely. Sure.
I'm very sorry.
All right, so today I just wanted to share a program overview and the progress that we've made in our school-based health center programs. Just as way of background, the school-based health centers provide acute, preventive, and primary health care through clinics located on school campuses. And the idea is very much to be able to provide care where children are, which is school. Some school-based health centers also provide expanded services like behavioral health, sexual and reproductive health, nutritional services, or vaccines. And in the state of Maryland, there are 89 school-based health centers in 16 counties across the state. In 2022, through the action of the legislature, the school-based health center program was moved over from MSDE to the Maryland Department of Health, and along with that, $6.5 million from the blueprint was provided to support and expand school-based health centers in the state. Just a data snapshot, there were 30,000 clients who were enrolled in a school-based health center. Of those, only 20,000 actually access services at any time. And for those 20,000 individuals, 17,000 students and a little over 3,200 non-students, there are 48,000 visits were completed. You can see in the map here just the locations of all of these school-based health centers and the 161 different zip codes that were provided services. Really wanted to focus on the strategic priorities for the school-based health center program. There are 4 core priorities, and I'm not going to go into detail on all of these, but I do want to hit some highlights of each of these. The first priority is to build a sustainable financial model for school-based health centers, and I'll expand on that. Second is to expand comprehensive school-based healthcare services. The third is to define and standardize the expected quality of care that school-based health centers provide. And the last one is to develop a robust foundation of data that describes and demonstrates what the school-based health centers do in terms of operations, quality of care, and value that they provide. So one of the items in the first one for just developing a sustainable model is what we're doing with our grant funds. We initially identified some limited financial support for.
IT problems. Remember that what I mentioned at the beginning that it may happen, it happened.
All right.
So give us a second. Thank you.
You're okay.
Thank you for your patience, everyone. Okay.
You were on here? This was
yes, that was the slide. We're good?
Yes. Thank you. Thank you again.
So just picking up with in terms of the grant funds that we have in FY23, MDH established new grant programs to address operational funding and infrastructure separately, and also created a new stream of funding for planning and opening new school-based health centers. And I think that's the most important part of what we're doing with these grant funds, to be able to expand services. The other really important piece of sustainable financial model is looking at how we can improve billing practices and capacities, including revenue cycle management. Maryland is different than other states. Most other school-based health centers across the country and other states derive a much larger proportion of their revenue from billing. In Maryland, that's not the case, and that actually leads to challenges in terms of sustainability and expansion, and that's why we're focusing really quite targeted on this piece, how we can expand that, and particularly with Medicaid, looking at how we can expand billing within that, and also how we can leverage federally qualified health centers who are able to receive enhanced funding for Medicaid patients, of whom many of the students who are receiving services are Medicaid eligible. And so that's really a key part of what we're doing, because we can't keep finding more and more grant funds to put into this. That's not a sustainable model. Billing has to be a part of that. So we've updated our billing manual. We've changed regulation to permit Medicaid reimbursement for sport physicals. We've looked at the provider IDs and disaggregated them, essentially uncollapsed them, so that we can understand better where the billing is coming from within these school-based health centers, and then also working to enhance how we can learn what providers and the MCO need from the MCOs in order to be able to do this billing. So we are seeing an increase in billing and reimbursement from payers, and so that's the right direction, and that's the direction we're going to continue to go on this front. We're also looking at how are we expanding comprehensive services. And so one of the things that we've really made it easier to do is making it easy for new sites to be able to apply to become a school-based health center. And so we've hired a couple of staff to be able to do this, and we've approved 14 sites to be able to start as a school-based health center. Approving them is not the same thing as them starting. They still have to be able to build the infrastructure, staff up, build the operational capacity and the billing capacity to be able to do this. And so we put out 2-year planning grants to be able, for these school-based health center applicants, to be able to set up their infrastructure, to be to be able to do this work. We've awarded 4 organizations grants to date under this, and we're looking to, of those 14 that have been approved, we're looking to get 8 to 14 of them who are actually up and running and with true applications to start services over the next 2 years. Part of that is also an onboarding institute that will be able to support new school-based health centers so that we can give them the TA in a group setting so that they can both learn from the Maryland Department of Health and from each other. And another piece of this is being able to define and standardize the expected quality of care. Prior to the past few years, standards hadn't been updated in many, many years. And so we have worked on updating these standards with MASBIC and CASBIC, the two organizations that provide support to school-based health centers and provide guidance to us. And we are in the final process of actually approving those standards. We're also, as I mentioned, data is critical. It's critical to anything we do in public health and healthcare, and being able to collect data on what school-based health centers are doing. It involves standardizing our methodology for collecting that data. We developed our first ever individualized site profiles, summarizing each of the site's performance metrics. We've released an annual report, and of course mentioned the Learning Collaborative that we have. That's the Learning Institute for new ones. Analogous to that, we have a Learning Collaborative for existing school-based health centers. And with that, I want to thank you for your time. Like I said, this is just a snapshot of what we've been doing, but we're happy to answer any questions that you have.
And thank you very much for the work you do, Nilesh, and for, answering the phone when we need help, when we have a question, and for being available and being a partner to this committee. I'm going to start with Delegate Hill, followed by Delegate Olston.
Thank you. And I know the budget looks particularly challenging right now, so I'm really interested if you can get into a little bit more detail of what the payer mix is for both the students who are in these community health centers and if there are community members who are not students who are also cared for, what that payer mix looks like. Do you feel under your new model you're going to be able to go after all available insurers, or there's some that you won't be able to bill? And are there certain diagnoses and treatments, either because of age or parental consent, that you won't? And I guess the other piece of that is, do we get that information up front? Like just at the school year, do we just get insurance information, or is it only when they show up for a treatment that then we're running around trying to find out who their providers are?
Okay, so I'm going to actually turn it over to Dr. Wormser to get into some of these details.
Thank you, Delegate Hill, and good afternoon, everyone. My name is Ben Wormser, and I'm the Medical Director of the Maternal and Child Health Bureau at Maryland Department of Health. And I help to oversee the School-Based Health Center program, just for the record. For your questions, first off, the Maryland Medicaid makes up 39% of our total clients for school-based health centers. Another 35% are actually uninsured patients, and the rest are privately insured patients. Our school-based health centers are able to bill Medicaid managed care organizations without having a separate contract with them, but they do have to have a contract with every private insurer that they would bill, which is a little bit of an administrative hurdle for billing privately insured patients. Regarding the patient mix for each school-based health center, that is something that we leave to the local jurisdiction for them to work with their community to determine exactly who they want to serve. Every school-based health center serves the students that are in their school, but then in terms of the decision about expanding to the staff of the school, siblings of the students, and even the community members is left up to each school.
Okay. May I follow up? Thank you. So as we go into this billing model, one approach would be when people register for school to ask them, we also have a community school. Can you give us any insurance information? And you capture that whether they think they need to use it or not. The other is to wait until they show up, whether the student actually has a need, and then go back to the parents. And in some cases, there's care that the parents may not even know about. So how do you work, or is that up to each jurisdiction, each school itself? How do you work knowing that you've captured all the insurance information so that you can actually do the billing?
So you may remember from Dr. Kalyana Raman, one of his first few slides, he mentioned that there was a large number of patients who were enrolled and then a slightly smaller number who actually used the school-based health center. So every school-based health center is charged with developing their enrollment procedures, part of which is gathering that insurance information about the patient. Some of them do it, well, really all of them will do it at the beginning of the year, sending it with that big packet of new student information. But then they have other means. Sometimes it's a digital QR code. Sometimes it's direct phone calls to the parents when the student presents for care, of also getting students who did not enroll at the beginning of the year enrolled if they need services, and insurance information is a part of that enrollment process.
Thank you. Thank you, Madam Chair.
Thank you. I have Delegate Olson, followed by Rosenberg.
Thank you. I just wanted to know, really it's two things. One, I looked at the map and I only see one little yellow dot in all of Prince George's County, Charles County, and Calvert County. And that dot is at the Montgomery County border. So I'm wondering, with these 14 new facilities that have been approved, are any of them in those jurisdictions?
So yes.
And if so, where?
Yeah.
So Prince George's County had 4 school-based health centers several years ago. The county of Prince George's determined that they wanted to move the school-based health center program from the Department of Health to the public school system. When they made that transition, the school-based health centers temporarily closed. We made connection with the Prince George's County Public School System and have been supporting them in reopening those 4 school-based health centers and a few additional school-based health centers that they have the infrastructure for, but need the additional equipment, and most importantly, a clinical sponsoring organization who will provide staff, medical procedures, an electronic health record, et cetera. And they are hard at work at that. Charles County also has one school-based health center that they have been developing.
Okay, thank you. Can I get a separate? Okay, and then the next question, with the federally qualified health centers, do you need legislation from us in order to apply and to become one or to partner with them? Or is it something that you all just need to do?
So with federally qualified health centers, we don't need legislation. So there are existing federally qualified health centers who do partner to or deliver school-based health services in Baltimore City's Baltimore Medical Systems has the biggest footprint. There are also ways for entities to apply to the federal government to become a federally qualified health center. And school-based health centers are a specific type of program that they identify. So that mechanism remains available to all of these entities.
So they can apply, the school-based health center can apply to become a federally qualified health center if they wanted to.
They could.
Any need for legislation from us?
Correct.
Okay, thank you.
Delegate Rosenberg.
Yes, what is your policy on telehealth?
Telehealth is encouraged and supported in the Maryland School-Based Health Center program. 51% of our school-based health centers provide some care through telehealth.
Do any of your facilities that have telehealth capabilities require that nonetheless an individual receive their care on site?
Those are not, there are no school-based health centers that have that requirement for their telehealth clients.
Okay, thank you.
Vice Chair Collison, followed by Delegate Shalega, then Delegate Taveras.
Thank you, Madam Chair. And I know Dr. Wormser hears this every time we have a Council for Advancement of School-Based Health Centers. I could not be more delighted and grateful for the work that Dr. Wormser himself, Dr. Chu, and the department has done in the development of the school-based health centers. I will tell you that when I started working on this now, where are we? We're in 24, so like 14 years ago, 13 years ago. The available data we had, they didn't even know how many school-based centers they had. Now we can tell how many students are enrolled, how many visits there are, what those visits are. We can, you did a very great, concise job. I could go on for hours with the things that you have done. So thank you. That's my first thing. The next thing I have, or the question that I have is there a way for us to facilitate the contracts with the commercial insurers to make that process more efficient and easier for the parents and the schools in order for us to be billing them more efficiently?
Well, first off, I'll echo our appreciation for your advocacy, Delegate Collison, not only on the legislative front, but on the operational side of things through CASBAC, because as we all know, bills get us so far, but then there's the implementation of it as well, and that is the strength of the program is in large part to your work. I think that's a really wonderful question and an important sort of next frontier for the school-based health center program. I, to be perfectly honest, don't know enough about policy around private insurances to be able to fully answer your question, but it is one we can take back to our team and provide a response for you.
And if there's something that we can do to help, you know where I live. Thank you very much.
Delegate Shalega.
Thank you. Thanks for being here. So you said the payer mix that Delegate Hill asked you about, 39% Medicaid, 35% uninsured, the rest are commercial payers. Tell us a little bit more about the 35% uninsured. Do you try to capture payment for any of that?
So the efforts to capture out-of-pocket costs are left to the billing procedures of the local school-based health center. We do encourage them to make an attempt to do that. But I will note that, this is one area where the grant funding for school-based health centers is really, really important. There is not a school-based health center program across the country that is not in some way reliant on grant funding to be able to operate. And so when it comes to providing care to those who are uninsured, they do have to rely on that to some degree. But they do take out-of-pocket payments from uninsured patients.
So they do ask.
Yes.
Of course, we want to provide health care, but, if you don't ask people to pay, they won't pay. So, all right, thank you.
Yeah.
I have Delegate Taveras.
Thank you, Madam Chair. In a follow-up to the question that my colleague made, Delegate Alston, I do have some questions regarding the school-based health clinics that should have been in Prince George's County, because we did have P3 schools that we constructed with space available for clinics, because I'm insured. And they're right around the corner of my house, and it took basically next door to the Mary Center, which is a federally qualified health center. So in addition to La Clínica del Pueblo, which is also right down the street. So the thing is that, all the pieces are in line, and I don't understand where the disconnect is, where we now do not have, not to say that those products aren't in the community, because those clinics are still open, thankfully, but the thing is that they're looking to replace them and close those clinics. And so where are they going to go? And so I'm very concerned as to what's happening in the county and why those clinics are not already in our schools and accessible to the community. Are you familiar at all with those conversations?
To some degree, as much as I can be at the state level, but it has, the Prince George's County Public School System is working very hard to open those school-based health centers, and the main, they're a public school system, and so they need to partner with a clinical organization to be the clinical sponsoring organization for those school-based health centers. And I know that they have been working hard on that effort. We have also awarded one of those 4 planning grants that Dr. Kalyana Raman mentioned in his presentation, went to the Prince George's County Public School System to help them conduct a local needs assessment and help to furnish some of the some of those school-based health centers that you have built. One good piece of news I can say is the hardest part of opening a school-based health center is typically that building of the site. So having that is a huge resource for helping helping these school-based health centers get off the ground.
Okay, I'll leave it there. I'm not gonna say, I'm troubled because of the proximity and why it hasn't been resolved.
Delegate Taveras, we share your concern, which is why we wanted to give them one of those planning grants so that they can get those sites back up and running.
Thank you.
But the local program, the jurisdiction has to agree, right?
They do have to set it up and
They
operate
have
and
to
run
set
it.
it up and doing it. So I think Delegate Taveras, if you can work offline with the local jurisdiction, because it has to be done, and with the department, that would be great. Okay? Delegate Olston.
Thank you, Madam Chair. I was just wondering if you could give us the information on where those 4 school-based health centers were in Prince George's County and where the new ones are anticipated to go with their planning. I think the members from Prince George's are very concerned that this has went to the school board, and rather they have the expertise to do this work as opposed to the health department. So I will convene a meeting with all of us from Prince George's and you all to discuss what we need to do to fix this problem, because we are concerned about this. Okay, if that's okay, Madam. And our Vice Chair, thank you. Thank you very much.
The Vice Chair?
Absolutely.
This is like her baby?
Yes, ma'am.
She went through 9 very painful months, and I'm just kidding. Thank you so much, and thank you for being patient as we ask the questions. And I know it's your first time in this committee, so welcome. But I believe, do we have questions for him? Anyone, any other questions? We do that for first timers. We ask, okay? So anyway, no one was listening, but now they are. So everyone has questions for you. I hope you come back.
Thank you.
Anyway, thank you so much for being with us again, and thank you for being a partner and for the great work, okay?
Absolutely.
Thank you for that passion.
Thank you.
Next, committee, we are going to the last panel of the afternoon, and then immediately after, we're going to go into hearings, okay? I'm going to call the Office of Minority Health and Health Disparities. I have actually the secretary, but I don't see, I think it's only going to be the director of the Office of Health and Health Disparities for the Maryland Department of Health, Ms. Camille Blakefall. So welcome whenever you're ready, and I know we're setting you up. And thank you for your patience as you waited. We really appreciate it. Good afternoon.
Chair, Madam Vice Chair, members of the committee. Thank you for the invitation to return. It's been a busy year. I look forward to talking about that more with you. For those who may not recall, my name is Camille Blake-Fowl. I'm the Director of the Office of Minority Health and Health Disparities. I've been in the role for about a year and a half, and I think when I was before you this time last year, I had been in the role for 6 months and was working through a lot of the organizational challenges that I inherited as the director, namely around grant funding and staffing. And so I'm excited to report that we resolved all of our FY24, painfully, slowly, but eventually, resolved all of our FY24 grant funding issues. And in the 5 months, my first 5 months, we have 7 employees total. 4 staffers needed to be hired, and so we hired 4 and were able to bring them back online, and that was sort of what expedited or advanced our ability to resolve our grant funding issues. We are still understaffed. I will talk more about that in my remarks, but we are working with a skeleton crew that I think has done a remarkable job given the limitations staffing-wise. I feel like I'm leaning in, so let me get comfortable here because we're going to have a little bit of time together. A quick reminder, since I know time is of the essence and you all need to get to bill hearings, I just wanted to contextualize this presentation with a mission and vision statement. You'll find that on our website. It was developed when the office was established in 2004 and has been tweaked over the years. I won't read it in its entirety. I'm sure you're familiar with it, but I did want to sort of center our conversations with a focus on the requirements of the office via legislation to address social determinants of health, reduce health disparities, and advance health equity by leveraging the resources of the department, by analyzing data, I'm paraphrasing here, by fostering robust public and private partnerships, and to really influence the overall strategic direction of the department with a vision of achieving health equity where all individuals and communities in Maryland have a fair and just opportunity to attain their optimal health regardless of race, ethnicity, ability, sexual orientation, gender identity, or socioeconomic status. Advancing. Okay, there we go. There we go. This is my fault. Thank you for leaping to assist. The office was established in 2004 by fearless then Senator Shirley Nathan Pulliam. And the legislation and subsequent legislation really added 24 statutory requirements that are to be carried out by the office to advance the objectives outlined in the mission and vision. We, in the interest of time and because there's a lot of duplicity in those recitals or shalls, we refer to them in the offices, the office shall do this, the office shall do that. We categorized these requirements into 9 broad operational categories that I will touch on here. Awareness, advocacy, education, outreach, advising the secretary, data, research, strategic planning, grant funding, partnering in coalitions, workforce diversity and cultural competency, and laws and regulations. It's been a busy year for the department since I arrived. You hopefully had an opportunity to review the FY 2023 annual report that we sent to the General Assembly. You probably received it in the spring of 2023, but I can't say for sure because once it leaves us, it goes through a series of reviews before it gets to you. As I understand it, you had not received a report from this office for a few years. We were thrilled to be able to get you one. The 2024 annual report is already complete and on its way to you. Again, I don't know where it is in the pipeline, but it is done. It highlights in greater detail some of the work that we have been doing, but I wanted to take this opportunity to discuss some of the work in those 9 operational buckets that you can read in greater detail about in the FY24 annual report.
It's due tomorrow. By statute, it's due on the 15th day of session, which is tomorrow.
Well, right. So it's, I believe, with the governor, and then the governor comes to you.
Yeah.
So I think somewhere in the pipeline.
Yeah, we look forward to it. Thank you so much.
As to the first operational category, awareness, advocacy, education, our office supports awareness, advocacy, and education about health disparities through its work internally and externally within the department. Some of the examples that we've been able to institute or have continued since I arrived was the development of an MDH Health Equity Liaisons Collaborative. I'll be speaking more about that in a minute. Some of our Minority Health Month activities this year, our 20th anniversary conference, our communications initiatives. We've rebooted, revived the MHHD website. It had sort of laid dormant and that hadn't been updated. We have been trying to make it more interactive, more a place where folks can obtain information about what the office is doing or what the department is doing or what is happening federally. We continue to collaborate with our grantees to promote health education and health literacy. And we also have returned to providing quarterly assistance to our grantees, both on an ongoing basis and as well as on an ongoing basis. So we provide quarterly technical assistance. We bring them all together, and then we provide ongoing technical assistance to help them wade through some of their questions programmatically about grant funding and the like. Here's just a highlight of our 20th anniversary conference where we were honored to celebrate Senator Shirley Nathan Pulliam and her leadership and vision in establishing the legislation that created this office. She was the recipient of a Health Equity Lifetime Achievement Award, and it was a highlight of the day. Our second area, advising the Secretary and MDH. We do this both internally and through the relationships that we have or the seats that we hold or fill on the various commissions across the state. I don't work alone, though I think a lot of people think so. There are others in the office that are sitting on these commissions or supporting the work of the office to ensure that we are fully staffed with our Health Equity Liaisons Collaborative. Our root cause of health initiative within the Public Health Services Administration is Dr. David Mann, our epidemiologist, focus. The Commission on Public Health, Commission on Health Equity, AHEAD, health impact assessments. That's the health and all policies approach that everybody is familiar with that hasn't really taken hold in the state. We are, right now, we are working with the Office of Governmental Affairs to implement health equity impact assessment for all the bills that are coming to our shop. So prospective laws, not current policies and regulations, but we're also working with Johns Hopkins to sort of build out this idea of health and all policies, similar to your racial equity impact assessments, health impact assessments with Dr. Keisha Pulliam at Johns Hopkins. And so we are thinking about ways to embed equity at the front end of bills or laws or policies that are prospective in nature, as opposed to trying to remediate once they're in place. And some of the work of the collaborative, really the current work, the key initiative is to develop a standard definition of health equity. Most other states, particularly departments of health, have a definition of health equity. They have a definition of health disparities. The federal government certainly does. They have several, depending on whether it's Healthy People 2030, CMS, HHS, NIH. The Maryland Department of Health has never had a definition of health equity that really centers what Marylanders need. And through the collaborative and through my leadership, we are on the cusp of developing that and putting that on our website. And it will be, I think, with the Secretary's blessing, it will be the definition of health equity that we hope everybody will use across the state. This is more about the collaborative. In 2024, we started the Health Equity Collaborative within MDH. The collaborative consists of about 24 MDH employees, from CEOs to at our hospitals like Spring Grove, to our local health departments, to internal MDH employees. It really runs the gamut, to folks that manage our funding and our IT and our chief fiscal officers, because we know that equity and decisions about equity are really embedded into what we pay for and what we value. So these folks, these 24 folks, have come together to try to begin to embed this work throughout their streams of influence. And in that way, we can sort of have a broader approach to tackling issues of systemic, social, structural inequity that are embedded. I and the 6 employees with whom I work at MHHD cannot be every place. There are 8,000 employees. It is 1/3 of the state's budget. It is a big it's a behemoth. It's a systemic behemoth, and you really need eyes and ears everywhere. So by creating the collaborative, what we are trying to do is make sure that folks who are experts in their spaces have the opportunity to really identify those current systems and structures that are broken or that perpetuate inequity, and try to interrupt that, as well as anything that might be coming down the pike. Additionally, I've been working with my colleague, the new Assistant Secretary for Population Health and Strategic Initiatives, Elizabeth Crom. She and I joined forces in early 2024 to co-chair a Population Health Transformation Advisory Committee. It was a committee of community and public health, population health leaders to really solicit advice on, as we prepare to submit the AHEAD application. And I'm using AHEAD as a shorthand in the interest of time. I think you're probably most familiar with it, to sort of solicit feedback on what kind of population health, equity, public health considerations we should be centering as we submitted the application. And so that was a process that I supported the Secretary and the Department on, and we really tried to, again, we will continue to try to support equity-focused work through the creation of a community engagement strategy that will facilitate bringing the community voice into the AHEAD program and into our systems and structures. And we'll not only use it for AHEAD, but we will use it anytime MDH goes out to community and wants to solicit feedback. Oftentimes, community engagement is unilateral, it's transactional. Folks never know, well, I've taken this survey, but what does it mean? Will I hear back? Will it affect my community? How will it affect my community? And so what I and the team at MHHD, with appropriate staffing, will hope to do in support of AHEAD and just in support of the department and the Secretary is to create a comprehensive community engagement strategy that will allow us to sort of partner with community in a more thoughtful, meaningful, and inclusive way. Data and data systems, it's a big concern. Certainly it takes up, it's another bucket of several shalls in the legislation. The Secretary, through her vision, has centralized data and data analysis in a data office within MDH. That data office has been leading the charge on all of our data deliverables, all of our data outputs. Its leader is Katie Bide. She's our Chief Data Officer, and MHHD has been supporting Katie as she's needed our support or asked for our support in building out, some of these new data dashboards. I will share a couple still photographs in the next couple of slides to show you what those dashboards look like. it's very exciting work. She's brilliant and is really, leading the charge and making sure that we are all, again, creating a uniform approach to data that's interactive, that's user-friendly, and that addresses the concerns outlined in the legislation that MHHD has, but also the expectations of the Secretary. We've also participated in a health equity data learning laboratory. We partnered with 7 other states to learn best practices about how are they utilizing health equity data? How can we utilize health equity data to really address the systemic and structural issues and the disparities that we're seeing? Dr. Mann continues to work with public health on some health initiatives there. And of course, he also provides support for the data analysis in our annual reports and also the 2023 Maryland Commission on Health Equity report that was submitted. This is an example of this snapshot. This still is from the interactive data dashboard that Katie and her team developed. It's currently up and online right now. There are going to be 5 categories where individuals can search for information without having to ask MDH to help them. You can search, and I'm not the expert on this, Katie absolutely is, but you can search by zip code, by age, by any other, you can slice it and dice it any way you'd like. It's exciting because right now, this website has overdose, biosurveillance, and cannabis data up, with firearm violence and women's health data soon to come. And so you could, if you're in 21218, and you want to know what the overdose rate for fentanyl is for Black men over the age of 65 in 2019, you can go to this website and put in all of those variables and get that data in real time, which is incredibly exciting. This is a snapshot. It is still a work in progress of our health disparities report card, which is a requirement under the legislation to develop. We sort of developed an initial version. We shared that with Delegate Bagnall and the chair, and we've taken some feedback from that meeting in early December, and we continue to iterate. And we too hope to make this report card interactive in the same way that the data dashboard is. It is a work in progress, and Katie's continuing to evolve it, and we are continuing to support her. Research, clearinghouse, resource library. These are some examples of the ways that MHHD has partnered with our colleagues to identify, evaluate, and review strategies for addressing health disparities. We partnered with our colleagues in the Public Health Service to complete the state health assessment and state health improvement plan. I was invited to join the Board of Physicians work group to study the licensure of foreign trained physicians. We work with the Maryland Commission on Health Equity, the 1.0 version, before ahead to review state best practices for health equity frameworks. You can read the rest here. We provided an implicit bias training for MDH employees in April of this year during Minority Health Month. We use federal dollars for that, and we continue to provide grant funding opportunities and related technical assistance. I'm most excited about some of the strategic planning work that's happening. Like I mentioned, in 2023 and 2024, the Maryland Commission on Health Equity was charged with developing a health equity framework. They were in the midst of doing that work when the Maryland Commission on Health Equity was amended to meet the needs, or to advance the objectives under the AHEAD global payment model. MHHD and colleagues took the health equity framework that was developed, that was sort of still in development, and refined and expanded that framework, and is currently under the review in the department, and we will be publishing a health equity framework in the way that we're publishing a health equity definition in the months to come. Again, something other states have had, we have never had. It's incredibly exciting. In 2025, we will also develop our comprehensive community engagement strategy, and we're also looking to expand upon our language access plan. MDH has a language access plan. It's a federal requirement, but there's an opportunity to improve it. And we began looking at that opportunity in 2024, and we will continue, particularly now to expand and ensure that language access is provided for our three most commonly spoken languages in Maryland, which are Spanish, French, and Arabic. You are all familiar with our grants and our funding. We maintain 3 grant programs that we administer: the Minority Outreach and Technical Assistance Program, the Social Determinants of Health Program, and the Epidemiology and Laboratory Capacity Program. That is a COVID program. Those dollars will go away in 2026. We use some external funding. Part of our legislative mandate is to find federal dollars to support our work. We use federal public health infrastructure grant funding this year to support an implicit bias training, like I mentioned, for MDH staff. And we use the US CDC, the CDC dollars for our ELC COVID grant program. Also excited to report that we are on the cusp of hiring a grant writer who will continue to explore opportunities for federal dollars to support our work. I don't know how that's going to go, and provide technical assistance to grantees on writing compelling winning grants. This is what we've learned in the year that we have been here, that small CBOs do not write grants as strongly as Johns Hopkins University, for example. They just can't because they don't have grant writers in-house. It's not that they're not doing great work. It's not that that work shouldn't be funded. They just don't have a cadre of grant writers who can produce a grant that's going to win the day, whether it's a HERC grant or an MHHT grant. We want to support them. We want to teach them how to write really strong grants so that they have a better chance of actually being successful. So we'll be working on that in 2025. A snapshot of our community investments: we provided $4.4 million and 41 awards to 32 organizations in FY24. We have many, many partnerships, alliances, and coalitions that myself and my colleagues, the staff at MHHD, participates in. We are in partnership with state and federal government partners, MDH partners, community organizations like CASA, the Hagerstown Area Religious Council, Interfaith Works, Movable Feast, Latin American Youth Center, Chase Brexton Health Center for LGBTQ Health Equity, Jubilee Association, Open My Heart Foundation. The list goes on. We, not just me, but the team has been making these communications because really, I think for MHHD, our superpower are our community connections. That's what we do that no one else in the department is doing as robustly, and that's what we'll continue to do. Another area of priority and an area of focus in the legislation is workforce diversity and cultural competency. In addition to providing that training that was federally funded, I chair the Underrepresented Behavioral Health Professionals Work Group. It's a long title. Black, Latino, and Asian American Pacific Islander Underrepresented Behavioral Health Professionals Work Group. Again, I was invited to sit on the work group to study licensure of foreign-trained physicians. Our MHHD Cultural and Linguistic Healthcare Professional Competency Program grew out of legislation that required us to develop an implicit bias training program for clinicians, which has been stood up and in operation for a couple of years. And then we also support internship programs, and we bring both public health students and med students into the MHHD family and really sort of try to teach them about disparities and cultural competency so that when they become practitioners, they are now thinking about these issues, right? We know we need that moving forward. Laws and regulations: we support the Office of Governmental Affairs in reviewing health-related bills that are introduced in your legislative session. We also support review of existing laws, regulations, and policies within MDH. We do this through the Health Equity Liaisons Collaborative, who, like I said, are embedded in their respective administrations and offices and really have a bird's eye view of what the practices, policies, programs are and where there are opportunities for improvement. And those liaisons work with the legislative liaisons on doing health equity reviews. And by equity, we're talking about not just diversity across race or ethnicity, but rural versus urban, socioeconomic diversity. We're sort of ensuring that all of that is addressed. Looking forward to 2025, we'll continue and finalize our work on developing a health equity definition and the health equity framework. We'll continue expanding the reach of the health equity liaisons. We will support the AHEAD and the MCHI objectives of improving population health. We will prioritize the health of immigrants in the state in partnership with the MDH Refugee Health Program. We'll begin through our expanded language access efforts and then iterate from there as we see the need. We'll also continue promoting implicit bias and cultural competency initiatives, and we will, staffing permitting, this is all staffing permitting, assuming we have the staff to support this, really create a robust community engagement strategy. I think that's it, and thank you for your time. I'm happy to take any questions.
Appreciate it, and for all your efforts and your team in doing this work. I'm going to open it up for question now. I'm going to start with Delegate White Holland.
All right, thank you. Oh, thank you, Madam Chair. I first want to say thank you for being here and sharing all of these wonderful updates. I think I want to start a little bit more macro, right? Yeah. And so I know that, again, since this office was created back in 2004, and certainly want to honor and recognize Senator Shirley Nathan Pulliam for her vision and foresight to establish this office. And so now where we are, we're 20 years later, right? And so really at the center of this is about how we move forward as a department in ensuring that health equity and ensuring that as we continue to address health disparities, that it's more than just a checkbox, that it's truly integrated and institutionalized within our operations as a department. And so how would you say that our office is being able to really inform the culture and the environment of the department to ensure that health equity is not only applied as a lens, but really embedded in every action in which that we take? And so I'm wondering, as you have said and alluded, well, if staff permitting, right, if fully resourced and the like. So can you just describe what is it going to take for us to get there, knowing that that is the mission and the vision that I kind of see from what you've described here, and not just the function of the office, but really that's the larger goal of what we want to get at. But what is it going to take for us to get there if we're not there yet, which I suspect we're not there yet? But what's it going to take for us to get there to ensure that it's truly embedded in every single corner, nook, and cranny of this department?
We have begun the work of doing just that by developing this Health Equity Liaisons Collaborative. Mm-hmm. The whole point of the collaborative is to ensure that subject matter experts who are embedded across the department, whether they're at one of the 8 state hospitals, whether they're in the local health department, whether they're at MDH, they're subject matter experts and they're also health equity liaisons. And in this collaborative process, we are learning learning best practices and understanding sort of contextually how we have arrived here and how we move forward. We are developing that uniform definition of health equity that everybody will apply. And that will come out of the collaborative and then be sort of taken downstream into these nooks and crannies to try to ensure that there's a consistency and that staff understand that this is what we mean. And when you are doing your work, you should be advancing this principle, this mission, this value. So, the Department of Health has 8,000 employees. It's a lot of employees. MHHD has 7 staff. I do not have a secretary. I do not have a deputy director. I have 1 fiscal officer. I don't have any community organizers. I don't have any health policy experts. I have no pins for that. Not having a deputy director means, and not having a secretary means I do my own scheduling. It's a lot. And with 8,000 people, we are always thinking about how can we be the most impactful with what we do have, right? It's a half glass full. creating the collaborative seemed to me like a no-brainer because it was one way that we could begin to reach down and bring the message to all the nooks and crannies. It's not the only way. I've been in the role for a year and a half. It's what we have implemented right now. I would just sort of center our thinking around this idea that injustice and inequity are generations in the making. And so we will begin to scaffold an approach, but it takes time. And so I think increased staffing and funding would be helpful. I think this kind of work is particularly unique because it's not just about sort of building a widget or ticking a box. You have to sort of bring people along from a perspective of whether it's, a business case, making the business case for why we want to have equity and healthy communities, or if it's some other value that people can equally and share and recognize. You have to make sure that everybody at baseline understands that and is operating from that place, and then from there you can begin to build.
Mm-hmm. Madam Chair, if I may, just one more, and I'm going to leave it alone. So, I mean, I appreciate that, and you kind of articulated, fiscal, resources, staffing, and the like. One of the other things, and how I have been able to kind of piecemeal some of the data, I'll just say this, is that when we look at health disparities, they are still persistent.
Yes, they are.
Right? And again, the burden shouldn't necessarily be on one office. It's everyone should take ownership of this, right? But in thinking about that, this is the entity that provides that strategic vision and really being the compass to address this. I think it's really concerning that we are where we are. And so, given what you just articulated, can you also expound upon, what is it that's truly holding us back? And we can look at staffing. Let's say that you have everything in place, right? I'm not saying that this is going to be the session where it happens, given where we are. But let's just say, ideally and hypothetically, if you were to have everything on your wish list, what is truly holding us back from addressing health disparities in an intentional way that will effectively get us to a place where they no longer exist, or that we're moving in the right direction across all these indicators?
Sure. Well, I would say that the healthcare delivery system as a whole would have to shift. You have embedded structural systemic disparities across the entire delivery system, and you have to address it holistically. One office with 7 people or even 20 people, quite frankly, or even the Maryland Department of Health, which is one piece of the healthcare delivery system, is not going to root out inequity. It's not going to address disparities. I will say that the Secretary's leadership has created a data office, and so the work of data analysis is not centered, it's not in the Office of Minority Health and Health Disparities anymore. It is now centralized so that we can speak with one voice and have uniformity. And that vision includes, access to data around disparities. The Secretary has absolutely prioritized that. That work is now coming out of the data office. It is not coming out of MHHD. We are subject matter experts. We see our role as making meaning of that data. And so if the data is being collected, whether it's being pulled together from CRISP or someplace else, and Katie sort of mapping it out on a dashboard, we certainly, and under the AHEAD program, we will do this, a model, we will do the same. We will sort of provide, we will support making meaning of that data, of what we're seeing, and reconciling that with what community is telling us. But data deliverables are not part of what MHHD is doing anymore. But it is being done. It's just being done in another shop.
Thank you. Martinez, followed by Delegate Hill.
Thank you so much, Madam Chair. And I want to thank the director for being here today, and also thank my colleague for the questions that queued us up. This is why I love HGO, because we really try to get to the nuts and bolts of what's happening for our communities. Minority health, the disparities for those communities matters a lot for me. It's the communities I represent and the communities I'm a part of. Last year, when you were here, I asked about representation in your office staff and Latinos, and was told the same around PENS. We're doing our best Can you update me on where we're at with diversity on your staff, particularly when it comes to Latinos and Spanish-speaking proficiency, not conversation, but professional proficiency in your office, just to make sure that we're communicating with all of our communities, particularly our largest immigrant group?
So we have, I haven't asked people to self-identify what their orientations are. I am just going to make, based on what I believe to be the case, we have one Latina on our staff. We have one gender nonconforming individual on our staff. We have women on our staff. We have Black women on our staff. And we're just a total of 7. So that is where we are today.
And something, too, I want to get to the nuts and bolts of. There was a term you continue to use, and it was centering. And I think we hear that a lot in our language, but maybe don't always have the same understanding. Can you explain to me what you mean when you say center or centering, and provide an example of that in your work?
It's about empowering those who have sort of not been integral to driving the systems and structures that govern their lives, whether it's in healthcare delivery or elsewhere. And so when we think about reaching into communities and funding community-based organizations, you know, we are working with our community-based organizations and we are saying, you know, we fund anything related to social determinants of health. You tell us what your community needs. You tell us, we won't tell you. And then we work collaboratively to identify, well, what are reasonable benchmarks? You know, what are the reasonable performance measures? What do you think you can reasonably do with your limited staff? And how can we support you? And then how can we provide technical assistance? But you, community-based organization, will drive what it is that you need. We just tell you broadly, we cover social determinants of health in a grant. Minority outreach and technical assistance is broad. And we do provide some governing definitions in our RFAs, but they're fairly broad. And the applications we receive are fairly broad. And we're doing that so that we can allow organizations to sort of tell us and drive for us what it is that they need, and then we talk about, like, what are the expectations we have to meet in order to be consistent with, like, the grant terms from state funding perspectives, or the federal government may have certain expectations, and we have to make sure that those are included. But otherwise, it's really up to the CBO to tell us what they want to do and what they're seeing in their communities, and to then the solutions that they think are going to work, we will fund those. And so that's what I mean by centering.
And the last thing is not a question, but, you know, one of the things that my colleague mentioned was around just the long-term existence of this office. I know the problems we're tackling have existed much longer, but the approach that we have around having individuals be in the driver's seat of their own liberation, maybe we can retweak or rework so that your office has all the tools necessary to make that actual model successful. Because I don't necessarily see the outcomes that we need right now. And with the lack of support from Washington coming and things of that nature, we know that these types of offices are really going to matter for the people that I hold closest and nearest to my heart. So thank you, Madam Chair.
We have next Delegate Hill, followed by Bagnall, followed by Rosenberg.
Thank you, Madam Chair, and Madam Executive Director, thank you for the work and for the presentation. So I guess I'm going to pick up where my colleagues have been. There was, as you stated in the beginning, a period of real understaffing. I'd like to get a sense of what you think those causes were, how you've corrected it. You said you have staff. I'm not clear if that's your pinned and staffed up to 7, or you're pinned for more but currently have 7. So I'd like to know about that and what you think going forward needs to be done to prevent the same thing from happening, where you lose staff, where you stop putting out reports, where you stop being effective as a department in the job.
Thank you for the question. I can't speak to the climate or the protocols for the directors that preceded me. I don't know why there was mass turnover. I just know that I inherited mass turnover. I would also say that I think my anecdotal observations is that this office, while it's existed for 20 years, has not been a priority for 20 years. And I would imagine, though I can't speak for the 4 directors before me, there were challenges with sort of getting at the table to do the work, right? I'm a Shirley Chisholm kind of gal, so I will bring my folding chair, but there are limitations if you don't know what you don't know, right? If I don't know the meeting is happening when we're talking about disparities in maternal mortality and morbidity, if nobody tells me that that is happening, I will inquire, I will poke around, I will look to, get in there, but so much, everything moves so quickly. Again, major, massive department. So you do try to embed yourself in the work that you see are priorities and for the department and lend our voice from the perspective of communities of color, of marginalized, minoritized communities. If I'm not at that table, that's why I think the Health Equity Collaborative is really helpful, because those people will probably more often know about it or be at those tables. I have a great relationship with the secretary. I know that she shares my interest in moving the needle on disparities, but I think that with respect to our PINs, I inherited half of the staff needed to be replaced. We hired folks to succeed them. I have 6 PINs, including myself, and then 1 contractual person. That's what I have. And so we are working within the context of what we have. I cannot speak to what happened before me. I do not know why it wasn't working. I do not know why there wasn't more effort. I do not know why this office didn't produce more results. I've been in the role for a year and a half. We are trying to move the needle. We have developed a collaborative. We are coming up with a definition of health equity. We are trying to create a framework for folks to think about this work. We are trying to be present as often as we can and raising the red flag of these issues. If that is all we can do. I don't lead the department. I can't make the final decisions, but we will absolutely continue to surface and elevate these concerns and do our best to insert ourselves. And then that's sort of all we can do.
May I follow up? Okay, thank you. Follow-up question. So I'm hearing some initiatives that seem to be designed to deal with the reality of being short-staffed, right? So you talked about working with or creating the collaborative and the hub. You talked about the department, the overarching health department having centralized the data. That takes a load off. I don't know if you are also looking at if there are any shared positions, so you need a grant writer. Are there other departments with whom you could share a grant writer? Not as great as having one dedicated, but I'm interested in sharing in other forward-looking ways that you think you can take advantage, or not take advantage, but leverage what other resources may be elsewhere in the department to help this department be more successful. And at the same time, you started off talking about the 20-odd tasks that we've burdened you with. So are there charges that if push came to shove, you would either deprioritize or ask us to lift and shift somewhere else?
Yes. As to your latter question, I'll start there first. Yes, just within the last couple of months, my colleagues and I in the office looked closely at the 24 and tried to figure out which of these were redundant, which were to be deprioritized. I would just say that when Dr. Carlicia Hussein and Senator Shirley Nathan Pulliam did this work 20 years ago, and Dr. Mann alongside them, who's been the only one in the office since the beginning, their charge and their lift was different. They were going around the state telling folks about the fact that disparities existed, and Dr. Mann was providing the data to prove it. So this is what a disparity is, right? This is what a social determinant of health is. That was a lot of educating that needed to happen, and that is what they were doing. 20 years later, it's far more amorphous when you talk about advancing equity. to be quite honest, to be quite frank, this day of all days, I don't even know that you can talk about equity, right? But we don't want to get sidelined by this idea that the nomenclature, it's the shiny thing over here. We're going to spend 6 months changing the names of offices and not doing the work. Correct. Right? So, but there is a real, there's real attention that has to be paid to the environment in which we find ourselves, which is a different environment than Dr. Hussein and Senator Nathan Pulliam found themselves. And so it is a different time. It is a complex time. It is a nuanced time. Not everybody supports the work of this office. The state does, and certainly we have your support, and we are grateful for that. But it's a matter of not only do we have the realities that the data continues to show us about disparities, but we have perspectives that differ on the value and importance of this work. So again, we push forward trying to always lift up the realities that the data still shows us. And we say, we recommend that you do something about it. We recommend that there be shifts, right? And, again, I have a partner in the secretary who really is committed to that as well. There are other social and political considerations, at play, and you have to manage all of that. That is above my pay grade. But we are continuing to push forward on the charge that has always been before us. And, I would say that the success or failure of this office will be not just on us, but on systems and structural change, healthcare delivery system-wide.
Thank you, Madam Chair, and thank you for being here today. And first, I want to acknowledge that it's hard to come and answer questions for things that occurred before you were in this position. And I think our health secretary would agree with that. That being said, I think you can understand the frustration of this committee because we do support this work. As chair of the Public Health and Minority Health Disparities Subcommittee, this is, firmly in our wheelhouse, and we've done a lot of work as a committee. And the good senator had the foresight, 20 years ago, and then saw that there was still a problem and tried to intervene. And I think there's a broad question of, we have continued to do this work, we have continued to intervene, and at what point does this agency lead instead of respond? And I think that's the hard question that we have to ask. I know that you had mentioned that you had staff turnover, that there were staff that you had to replace, but I do notice that the staff who have been here and had that continuity, had that institutional knowledge, are not here beside you. And I'm wondering why they're not here to speak to not just the work that is being done, but why we're so behind, why the agency that was tasked with this 20 years ago is behind the department in general, behind the state, behind the legislature.
There's only one employee Dr. David Mann, who is a recidivist who was with the office when it started 20 years ago. He is watching virtually online, and he's our epidemiologist, our data expert. And everybody else is new within the last 2 years, 2.5 to 3 years. And so we've all been sort of learning together. And most of the folks who joined during COVID, with the exception of Dr. Mann, or the folks that I have hired since Dr. Mann. So it's a fairly new office, and we are, trying to build back and address, meet and exceed the expectations set out in our charges. And I would just, Senator, I would just note that I feel very strongly that we have been doing a lot of work to lay the foundation, to move the department in a direction that will finally sort of take where this idea of disparities holistically across the department can take hold. I don't want to minimize the importance of creating a definition of health equity that everybody has to abide by. At a minimum, it sort of says when the secretary mandates it or puts her blessing on it that this is something that we prioritize. And this objective, this value, is what we expect all of your work to advance. That's huge. Creating a health equity framework through which you can do this work. Again, other states have been doing it. We're not innovative in that way, but we as a state have not had it. It is a statement that we are prioritizing this work and that folks need to think about their work through this lens. And we're giving them a playbook to try to do that. So I think in the year and a half that I have been here, trying to get this colleagues to be thinking about this work and a framework through which they can evaluate this work. And then, the next step will be, comprehensive strategies, whether it's a community engagement strategy, which will come in 2025. So if I'm in an administration, developmental disabilities or public health, and I want to engage the community because I'm about to come out with a regulation, I have a playbook for how I do that. And I also know that it's a priority, that we have to empower and have those individuals in community most proximate tell us what these regulations should be or shouldn't be. And I know we have notice and comment rulemaking, but this is a much more interactive way to do that. So these things are coming. We are proud of what we are building. We are continuing to build on that. And through doing all of these initiatives, I think we do start to really have folks thinking about and prioritizing the need for addressing the disparities.
If I could have a follow-up. Thank you. And with all that in consideration and the work that has been done around the agency as we have progressed, that we've created the Maryland Commission on Health Equity. We have the Community Health Resources Commission. We had the AHEAD model that worked on that framework, that did the recertification. We have the health equity resource communities. We have the implicit bias training. Where do you see yourself as the conduit, as a member of all these existing efforts, not looking back to the original charge, but where we are now? How does this agency fit into the big scheme of our health department and our equity efforts as they exist now?
Oh, I think that's a great question for the secretary. I would say that we are, because I know that she has strong feelings about that. In my role as the director of the Office of Minority Health and Health Disparities, I do sit on all of these commissions, and I do lead various elements of the Maryland Commission on Health Equity. And we are working to try and ensure that disparities is a focus, and that we are being innovative in the ways that we are providing incentives to primary care physicians or whatnot, that we are thinking about the communities that are being served. For example, the AHEAD model is a very complex global payment model, very complex. And I am confident that most Marylanders have no idea what it's going to mean for them in terms of healthcare improvement. So if I'm a single mother and my child needs a vaccine, or my child needs a form filled out to participate in youth athletics, how is the AHEAD model going to help me get that? What does it mean? Am I going to get better care? Am I going to have increased network adequacy so that I can see a clinician and it's not 4 months? Are they going to ask me about my housing insecurity? Are they going to help me with my housing insecurity? This is what people want to know. This is what the AHEAD model promises to bring forth. So we have been talking about creating one-pagers, creating ways for individuals to understand what the model means for them when they go to the doctor, or if they can't go to the doctor, ways that it will improve their health and wellness. And you have to explain to folks in a way that they will understand. And I think our role in MHHD, always centering community, is let us create materials as we're bringing other folks in the healthcare delivery system, providers and payers and clinicians, all of whom are at the table and talking about the AHEAD model, and also some community leaders, but they may or may not understand. We had this session during the Health Equity Conference. It was dedicated to AHEAD. And we brought folks together, and we had two MDH leaders talking about the AHEAD model. And at the end of that 50-minute presentation, there were about 50 community FQHE and community leaders in the room. I asked folks, it's been a great presentation. Do you understand what you've just heard? Could you explain it to your patient when you go back to your FQHC? Could you explain it, to your community partners? And no one could. No one could explain it. They heard it, right? And they didn't have questions for the presenters. But when I asked them, okay, tell me what you've heard, crickets. So that tells me that we need to do a better job communicating with communities so they understand the benefit of the AHEAD model and how it's going to improve healthcare delivery in the state, and why it's going to improve healthcare delivery for them, and why we want to ensure that their voice is consistently at the table as we go through this 10-year, 9-year, 11-year model period, hence the community engagement strategy, to make sure that we're always bringing people back to the conversation and not creating systems, more systems, that do not that are not reflective of what they need. So that is a role that I take very seriously. That is the role that MHHD can take lead on. That's part of what we are doing. That's an example of the way that we center ourselves in the work.
Thank you. Thank you, Madam Chair.
Delegate Olson, followed by Rosenberg.
Oh, yeah.
Delegate Rosenberg.
Thank you.
Sorry,
Thank you
I lost,
both.
it's not personal. I lost my little list, Delegate Rosenberg. Going from
I got
memory.
bailed out by Delegate Alston, no problem. Do you get any federal money directly for your operation?
No, it's all state dollars.
Okay.
We do get, again, federal dollars to administer as a pass-through for a grant to grantees, but we don't get any.
So you don't think that, based on what you know at this time, that the change in policy at the federal level regarding equity has any effect on the work that you're doing?
It's premature to say. I don't know.
Okay, thank you.
Thank you, Madam Chair. So I've been listening, and I feel like there seems to be a disconnect with what I'm looking at as the original charge for what this office is supposed to do and what you're telling us you are doing. And so I would first ask, have you looked at the original legislation that created the office?
Yes.
Okay. And so in looking at that legislation, and I know you haven't been here that long, I'm curious, when you came in, did you conduct, for lack of a better word, a postmortem of what has happened up until the point that you had been there as it relates to the original charges in the legislation?
Yes, I reviewed some of the strategic plans that had been developed by some of the former predecessors and sort of read whether it was 2006 or 2015, sort of their plans for the direction of the office, and thought about how we can continue to advance that work.
Okay, so in doing that, you've mentioned a couple of times that you're short-staffed. Have you put in a request for more staffing?
Yes.
You have? Okay.
Yes.
Is that before the assembly or the secretary right now?
Is it before the, oh, you mean as a formal budgetary request?
Yes.
Not that I'm aware of.
Okay, so, because when you put in a request for more staffing, it has to go through the budgetary process for you to get pins to your office, right? You need more money.
I would imagine. So I'm not intimately familiar, so I'm going to take your word for that. I think that we'd have to increase our budget, at least our budget line item, to include more pins.
Okay, and I guess my question is, has that been done?
Not that I'm aware of. I think we had a couple of pins, particularly the deputy director pin that I was holding on to, that I hoped to fill at some future point, and now the pin is no longer.
Okay, and can I have some latitude? Thank you. All right, so with that being said, and you looked at the original legislation, I'm curious, has your office developed, or do you have a plan to develop, a statewide plan for increasing racial and ethnic minority healthcare professionals?
We are working on my representation on, for example, the underrepresented behavioral health professionals work group. We have an interim plan, and I chair that committee, and we will be developing a final report, which will be a plan for how we increase the number of underrepresented behavioral health professionals in the state. It will be a step-by-step strategic plan that will come forth in June. It's due to the General Assembly, to all of you, in June of this year. That's one example of us trying to advance that work. Our health equity framework is also another strategic plan where we're not talking specifically about workforce, but we're talking about the need to deal with racial ethnic disparities and historically where we find ourselves and how we can think about doing that.
Okay. Now, there is also a piece where you all are to develop a strategic plan to improve public services and programs targeting minorities.
We are working with, Dr. Mann has really been leading the charge from a data perspective, working with the Public Health Services Administration to think about our programs, the public health programs, and whether or not they're equitable in their reach, equitable as applied. And so it's not a strategic plan per se, but it is in partnership, because a lot of our work is done in partnership with our colleagues across the department as the subject matter experts. So Dr. Mann has been working with Public Health Services Administration to sort of look at our public health programs and see where we're failing in terms of reaching certain populations, and can we improve those programs for better outcomes.
Okay. There's also seek and create a statewide alliance with community-based agencies and organizations, historically Black colleges and universities, healthcare facilities, healthcare provider organizations, managed care organizations, and pharmaceutical manufacturers. Where is this? We have relationships with some of our historically Black colleges. We have a relationship with Morgan State University. We have some relationships. I didn't go through the laundry list of all of our partnerships. We've developed partnerships with organizations across the department, across the state, faith-based organizations. It isn't a formal alliance, but we are in partnership with these entities to try to meet their needs, hear from them, and advance the work that they are identifying. Okay. Can I? Okay. Make it good. Okay. I guess what I will close it with this. There was a fiscal note with the original 2004 bill. I would encourage you all to look at that and look at the items that were delineated in that note, because these are the things that we're expecting from the office and we're not seeing them. And I am very concerned because I served with Delegate Nathan Pullum when she was a delegate, and she worked really hard to make sure that this bill became a reality and that healthcare disparities are addressed in the state. And I don't know that right now this office is meeting the level of expectation that this bill was designed for it to meet, and that concerns me. And if there is a funding issue or a staffing issue, then those requests need to be made so that we are aware of it. But if we're not aware of it and there's no request before us, all we're seeing is what's not been done under the original bill, and that is deeply concerning because minority health care disparities are important to all of us. It is a very important issue that we're not going to rush through, so we will make time to hear it, and we will make the available resources that are necessary so that we can do the work, because people need to be healthy and they deserve good access to health care in this state. Isn't that so?
Well, I thank you for your partnership. I would just remind the committee, I've been in the role for 16 months. So 24 shalls in 16 months is a tall order. Right. And yet we are very much aware of those 24 shalls, and it drives all the work that we do. And we will continue to prioritize every single one of them. We are happy to provide some language for those that we think maybe are redundant or duplicative at this point. It has been a pleasure to lead this office. It has been 16 months. There are 24 deliverables. I just would remind the committee of that.
Thank you.
Okay. Delegate Bandari will have the last question, and then I'm going to wrap us up because we have hearings. But I do want to say this is an important issue, which is why I am allowing it. This is important, like rural health is important, right? Those areas that do not get the resources, right? Like broadband, not having enough hospitals in those areas. Those are issues that I care about in this committee, where communities do not have the resources. And I think I will wrap us up, and I have a couple of things to say. This is not, on behalf of my committee, who is a very respectful committee, but I think you can tell that they're frustrated, right? Because, and it's clear, and they're doing it, and I thank you for being so respectful, because that is what we are here. And I thank you all for being patient as you hear. Because today this is this issue, today, tomorrow may be your issue, so it's important to be patient as well, okay? Delegate Bandari.
Quickly, thank you, Madam Chair and Director, and we also have an AAPI caucus. There are close to 500,000 Asian Americans. If you need any help from our caucus,
thank you.
When you do the town hall, please let us know. Thank you.
Thank you.
So I don't see any other questions, and I want to wrap us up. I think that what you experience is a frustration of that office not functioning well. And yes, you got there 16 months ago or so, but we expect some of these things to happen. And for those of you that are wondering, why is this important? It is more important, especially given what's happening in this country right now. And it's so important because the fiscal note, and I asked our lawyer to allow me to have the fiscal note for House Bill 78, which was the bill that established the Commission on Health Equity. And in that fiscal note, I want you to pay attention to some of the disparities. You may not agree with the term, but you cannot disagree with the data. The number, the science, I want to believe that we can all agree on it. And this is what it says. Data consistently shows ongoing and in some cases growing health disparities in Maryland, including right after the impact of COVID-19. When we heard during COVID-19 in Maryland, we have 23 jurisdictions plus Baltimore City, 24 total. The county with the highest number of COVID-19 cases in the entire state was Prince George's County. Prince George's County is the county with the highest number of people of color. Baltimore City was one of the top 4. The SIPCO with the highest number, the entire SIPCO in the state of Maryland with COVID-19 cases was 20783 at the height of COVID. Does anyone know who lives there? The immigrant community. And by the way, immigrant community is not just Latinos. It is Africans. It is Haitians, right? It is Asian, you name it. So it says here, while Black it says here also the maternal and infant mortality, incidence of HIV and emergency room visits for substance use, asthma, diabetes, and hypertension are very high in these communities. While Black individuals back then, and this was in 2021, comprised, now it's higher, it's 30-something%, 29.8% of the Maryland population, they represented 36% of the COVID-19 death, okay? Maryland's maternal mortality rate for Black women is 3.7 times higher than that of white women, and the racial disparity has widened in recent years. And if that number was for white women, whoever, we will be examining that issue with the same passion because we care about everyone. Maryland's infant mortality rate for all races, ethnicities has remained level but remains the highest among Black, okay? The incidence of HIV for all races, ethnicity has generally declined in Maryland. However, it has not done so for the Black community. And the ER visits for Black is a lot higher than everyone else. The numbers do not lie. So when we're facing these very difficult challenges of, cutting more than $200 million to the disability community and Medicaid, where in Maryland we have it's almost 1.6 million people, and our population is a little over 6 million that are Medicaid. And let me remind you, to qualify for Medicaid, one individual, you have to be within 138% of the federal poverty level, which is a little under $21,000. These are the very poorest. And as we're making these decisions, it is important to have a strong office. So I have, with a lot of respect, the following recommendation for you. Now that you have been there 16 months, I think that, and you are on all these commissions, I think that I would ask you respectfully to spend the rest of whatever time you have in that office meeting, for example, with Hopkins and Maryland University. They have health equity centers. Once a month, meet with them. Once a month, have breakfast with them. Like, make it permanent. With CRISP, who's our state health information exchange, they have a lot of data. So for those report cards and information, they have it. They have a lot of data that you could use. I want to hear from you about diabetes, about heart disease. I want to hear hypertension, those diseases that affect, primarily people of color, right? And I know in Prince George's County, those are the diseases that are killing people, that are killing Black people. I want to see and hear more about the grantees. What kind of grants were given to what organizations, what were the outcomes, right? What were the goals? And if you could put those also on the website, that would be great. The HSCRC has a lot of data as well. Ben Steffen's shop has a lot of data as well. I want the Black colleges, they're willing to work, to see what else they can do and help with that data. This session, I'm very blessed to have 3 out of the 6 fellows are doctors. And I got them from Hopkins University, and they're getting their master's in public health. They're fellows. See if your office can develop a fellowship program where you get these doctors and masters in public health that can help you do some of this work as well. They are amazing, clever, intelligent people. Actually, 3 of them are listening right now because they're in the back as well. I think that there is a need to update this regulation, right, to reflect the times. I would like to challenge you to go back to the office and in the interim, contact Delegate Martinez, Delegate Hill, Delegate White Holland, Delegate Alston, Rosenberg, Hutchinson, Shalega, anyone to come in the summer and meet with you and try to work on a bill that will change and have that statute reflect the times of what we're doing. What I also would like for you to do respectfully is to think about what kind of legislation, as you're talking to Hopkins, as you're talking to Maryland, the grantees, you think that this committee should be introducing, right? Because we don't always, no disrespect to any of you, we don't always have the best ideas, okay? But if they come from you based on the data, that is more practical as well. So what you heard today was a bit of frustration because the office hasn't really delivered what it should. And there comes a time, again, respectfully, where we have to stop the studying and do. And we want things done. Regarding the grantees, I know part of the charge was that the office needed to apply for and accept any grant from the federal government. I don't know that that would happen, but it also says private foundations. It also says any other sources available for programs. And there's a lot of foundations in Maryland, a lot of people that have resources that now especially will want to give money and help. We don't want to just come to you with problems. I truly mean it. We want to be part of the solution. And any of these members here, all 22 of them will make themselves available to help you, okay? We want to help. We want to be part of the solution as well, okay? I know that was a lot, but as I was listening patiently, I try to summarize us so that we can have some task and things to do moving forward so that when you come next year, we can sit here and say, you can say, okay, I work with this institution, that institution, we got these grants, we met with these nonprofit, we have these programs, I have 5 bills for you this coming session, you know, and can you guys come and help? I mean that respectfully, okay? I know it's not an easy job at all, and it's not easy, but you're not alone, and we're willing to help you, okay? We have access to the library here as well. We could do research. We can connect you to different people. We are really willing, okay?
Thank you, Chair. I really appreciate the guidance and recommendations. I just want to add, again, when you receive our 2024 annual report, much of what the Chair has asked to be delineated, particularly about our relationship with our grantees and grantee impact, is delineated. In my time, I have met with some foundations. I've met with the ABLE Foundation. I have a standing meeting with the Maryland Hospital Association. I've met with the Health Equity leader there, Tiffany Wiggins, and these relationships are happening. I didn't delineate all of it here because time is of the essence, but those relationships are happening. The annual report will reflect some of that, and we will take your feedback absolutely and your suggestions and move with those as well.
Thank you. And I know that Delegate White-Holland has a bill that she's working on to create a dashboard. And I think if you can meet with her offline, that will be wonderful as well. And thank you for your patience as you patiently answer the questions. We really appreciate it, okay? We do not take it for granted, all right? But we do want you to do well, and we want to be able to help get those tools, okay?
Thank you very much.
Have a blessed evening, and I want to and thank your staff for us.
Will do.
All right, because
they're all watching.
They're working hard. I know that we passed the implicit bias legislation, which is working really great. We hear about people taking the classes, so thank you so much for running a great program and for being available for us, okay?
Thank you for having me.
You're welcome. Have a blessed afternoon. For the committee, we have 3 bills. They shouldn't take long because they're departmental bills. If you could stay seated for a second, we need to go down and then come up again. 1 minute. For everyone waiting, thank you very much for being so patient with us, all right? For those of you at home, thank you for giving us some grace, all right?